and there is apparent lateral subluxation of the tibia, which makes the fibular head more prominent. This development disorders usually presents at 1.5 to 2 years, and it's never seen before 1 year, and very rarely below 2 years. Hence, we cannot expect a Blount's disease to develop below 2 years. And so if we are getting a deformity after 2 years, we should suspect this as one of the cause of the deformity. Such patients are usually obese with a compressive force, which leads to its development. Our main aim is to detect early the patients presenting as a physiological bowleg, and to detect the chances of it developing a Blount's disease it's although less reliable, but it is the MDA, the metaphyseal diaphyseal angle, that is the maximum transverse diameter of the metaphysis with the long axis of tibia. If it is more than 11 years, the chances of such tibia going to the Blount's is very high. This is a called staging with age. With the age, the deformity progresses and the physeal changes also appears. In the stage 1 and 2, which is the manageable with the braces and osteotomy, which appears at around 2 to 3 years, and in stage 6, which is a very old and neglected cases in which there is gross disturbance of the physis. And in these stages, we need some physeal reconstructions. But our main aim is to detect and treat at the age of 4 to 8 years, because it is this stage, if we treat, we can get a good correction, and the chances of relapse or recurrence is less. But once we go for the physeal corrections, the chances of success is very less, and we can get less satisfactory results. Bracing is very important. We can use the traditional valgus producing KFO, or the elastic Blount's brace is also available in the pattern. It is useful in children who are below 3 years. And it has been reported that it can correct up to 50% of the deformities in the stages 1 and 2 with just 1 year of the use. Many literatures suggest that even only the night bracing is equally effective as 24-hour bracing, but we prefer daytime bracing at the time of ambulation and weight bearing. The point to note is that any observation or bracing is not recommended after 4 years in the patients presenting in the stage 2 or if the deformity is more than 10 lesions. Our main aim is early recognition and realignment of the limb, because it avoids the compressive force over the medial epiphysis, which is the main cause of the progression to the higher stages and recurrence even after osteotomy. Our goal is high tibial osteotomy just to correct the deformity. We can either go for the closed wedge osteotomy or open wedge osteotomy or dome osteotomy, chevron osteotomy, or anything, but we have to get 5 degrees of overcorrection with lateralization of distal fragment in the stages 2 and 3 for deformity not corrected with brace by the 4 years of age. And physeal osteotomy is required in the advanced stages of 4, 5, and 6 with guarded prognosis. This is a case of adolescent tibia vera presenting very late after 10 to 12 years. And the main aim of surgery or consultation is the cosmetic corrections, because the child is going into the marriage age. Such cases are relatively easy to treat because the physeal disturbance is very less. You can see the angulation in the proximal tibia. And we went for the infrapatellar oblique chevron osteotomy. Stabilize with just KOIs, and we can get good functional results. This is the late presenters. You can see the abrupt angulation in the proximal tibia and typical physeal changes. These slides are got 3 stage. And there's a different slope in the epiphysis. In this, we went for the double osteotomy to lift and realign the leg. But as said earlier, the reconstruction is not very good and very easy in such cases. We went for the seat correction. We put corrections, but the medial femoral condyle, it overgrew to compensate the deformity, but the functionally the patient was satisfied with the good functional results. The take-home message is be alert if you are dealing with persistent genu varum after 2 years of age, and don't waste time in observation or bracing after 4 years. Rather, go for surgery.
questions on the presentations?
Just one comment on the last one that with the intra-articular deformity as well. I think you need to combine the extra-articular osteotomy with an intra-articular osteotomy if you want to get full correction there. Okay, so you need to elevate the hemi-plateau as well.
But the age was very advanced and the growth rate was not.
Doesn't matter. You still can do a hemi-plateau elevation and that corrected. You would have to put some bone graft, and one way of doing it is you need to excise a bit of fibula in this, so you put that in there. Yeah, so if you want to correct that much, you need to do a fibula osteotomy anyway. Yeah, you can use that graft to check up your hemi-plateau.
I now invite both the speaker, Dr. Manoj.
By the time Dr. Manoj is setting up, any conference needs participation of all the delegates, and we are privileged. We have number 1 registration by Dr. Hasnan. Please come forward. Dr. Amit Ajgaonkar, please present a small gift from the organizing committee to Dr. Hasnan. He's registration number 1 of this conference, GOFCON. ये जरूरी हो जाता है क्योंकि organizers are desperate to get people registered as early as possible. Come here. You will have the background also. And we had the lucky draw. So Dr. Rahul from IGMS is getting, basically you were the first one. That's why we are getting you, and you were just with Dr. John. So that's why we are presenting it to Dr. Rahul. You will be getting that from Laxo stall. So no more lucky draw today. You will be getting it. Dr. Rahul from IGMS. Thank you.
So, good morning, everyone. Once again, I thank Dr. Amulya and the entire GOFCON team for this well-organized meeting. So I'm going to spend the next 15-20 minutes talking on just giving you a broad flavor of what we encounter in complex problems. So the title is Complex Problems Made Easy. They're not easy, but you can kind of approach it in a logical way. So this is where I'm affiliated to. What do we mean by complex problems? That means there are a whole bunch of issues to deal with. It's just not one. It's just not an obvious deformity. I mean, even if you see, take for instance tibia vara, which is the previous speakers, there are huge issues. It's not just a deformity. There is gait abnormality. There can be pain, limb, if it's unilateral, limb discrepancy. Any intervention can cause stiffness, loss of motion. So you need to factor in all of those, and it's not just limited to that particular joint, because there can be secondary issues as well. So whatever approach that you choose to, and there can be different strategies to deal with this. You need to have, you need to be comfortable dealing with internal fixation, external fixation, guided growth, deformity correction, and the key thing that I want to kind of highlight is management of expectations. Because sometimes some of these problems, it's not that you may have to take several bites of the cherry to kind of have it sorted. So if the expectation is that there is one surgery which will cure all and be all for the rest of the life, that may not be realistic. And the other thing that you need to remember, so again, you may have a great result, and your objective is to preserve function right now, as well as to kind of for the foreseeable future, factoring in future growth. And some of these conditions, because of intra-articular problems, you may have to kind of factor in future deformity, future surgeries. So there is no point kind of distorting the anatomy, having multiple scars going in all directions. if that particular child or the patient is going to need a future hip or a knee replacement at some point in time. So preserve function as long as you can, but you have to kind of consider that, that there may be a situation of future surgeries. So I'm going to take you through, 3-4 cases. So here is a 12-year-old girl. The X-ray was briefly shown yesterday, presented with just prominence over the outer side of the knee. This is what her complaint was. This is what her mother brought her when she just started hitting her teens. So clearly there is a lot going on in the knee. It's not just the proximal fibula, just the prominence. It's a lot more than that. There were occasional locking episodes on close questioning, and there was a history of an infection, a so-called infection, around the year of 1 year. That's 10 years prior to that. And the child had been absolutely fine. But you see what she presented with. She had full ROM, there was dynamic varus, and she had a leg, she was unaware of it. She had a leg length discrepancy of about 3 centimeters. So clearly there is a lot more going on than just a simple prominence of the fibula or a deformity there. And so if you take a standing alignment X-ray, so all X-rays of the lower limb, I would urge you, including foot, you should, for any deformity planning or evaluation, you really need to take weight-bearing X-rays. So because of the clear intra-articular pathology going on in the knee joint, an MRI was done, which clearly showed the extent of damage inside. So if you draw your axis, you can see the extent of deviation. So now you start listing out what are the issues that need to be tackled. Yeah. So here you have the varus deformity at the knee, which is clearly there, and that is due to joint incongruity as well as proximal tibial deformity. Dr. John alluded to it. A lot of them have intra-articular deformities, whether it's Blount's or whether it's a post-infective sequence. There is limb length discrepancy. You can clearly see the shortening there. There is fibular overgrowth compared to the other side, and that causes left collateral ligament laxity. So you need to factor in whatever you're going to do with how you're going to correct that. You also, a lot of them have compensatory distal femoral valgus. That's a potent combination, proximal tibial varus with distal femoral valgus. Body tries to compensate, body tries to straighten the leg. And the only way that it can straighten out a proximal tibial deformity, even in Blount's, long-standing Blount's, is to produce a distal femoral valgus. So and that is important, and I'll tell you why. You may ignore it, you can say, oh, that's just not too much. And bear in mind, she's still growing with a full knee range of motion. Okay. And I clearly recall telling the mother at that time that I think you should start finding, over the next 10, 20 years, find a good knee replacement surgeon. That's where it will probably end up as. And my job is to kind of delay that inevitable knee replacement until as late as possible. So that's the deformity. You can see the extent of varus. You can clearly see the extent of valgus and the distal femur. So what are you going to do for this? So we needed to address all of this, and this is the best way. I'm not saying this is the only way. You can stage it, and this is what we did. We did a fixate-resisted reconstruction. We elevated the tibial hemiplateau, incorporated that into the pin. We distracted through this lengthening. We did the fibular osteotomy. Fibula was pulled down, and the proximal wire fibula was anchored to the tibia, and an 8-plate for guided growth correction. That's her with the fixator. This is where she ended up as. Okay, that's the degree of correction that we achieved. We have restored the angle, and we have overcorrected, shifted the axis to the lateral compartment. Have we achieved what we set out? Have we achieved all our objectives? You can see that the joint line is parallel. It's not absolutely congruent. There's already a lot of damage, even preoperatively. So if you look at broadly, I've got the axis right. I've restored it. I've overcorrected it. I've corrected the LLD. Fibula station is much lower now, so there's no laxity there. There's no dynamic instability. There is a secondary translation in the proximal tibia, and that's clearly visible, but she wasn't bothered by it. So 8-plate, once the femoral valgus is corrected, 8-plate was removed, 10 months after surgery. Okay, and I said, okay, that's good, well done. Follow up, patient is happy, the locking episodes have become much lesser, no pain, and she's concerned, as she's already now 13, 14, she's concerned about the Ilizarov scars and is talking to me only about follow-up, only about cosmetic surgery. When can I get that done? Yeah. So this is where she was at that time, more concerned with the scars. But she started to have some symptoms of what she said, the kneecap is now starting to dislocate. This wasn't a symptom. Earlier it was locking episode. Clever girl, so she could tell her symptoms very well. So now she's 4 years down, post-index construction. So she's having increasing frequency of patellar dislocation. So she's clearly saying, this is not locking, my kneecap is going. Locking episode is status quo. activity levels reduced. She's now getting into her 12th and getting into college. So mom says whether the knee or the academics, we don't know. We took an X-ray and look what's happened. The axis is shifted lateral. What's happening there? You know, I put the medial 8th plate to correct the valgus, but why did that happen? Yeah. So if you see the pre-op pictures, you can clearly see this is where I post-op at the end of correction, I had left the axis in the lateral compartment, and this has gone further down. So what's going on here? And measurement, distal femoral valgus, which is around 88, 90, has gone now to distal femoral alignment, has gone into valgus. LDFA is now 84. Okay, this is where she was at the end of correction, that's gone on to 84. So what's happening here? Look at MRI, there's a little bit more damage in the lateral compartment now because weight bearing is going on the lateral side. And this is well known to occur when you remove the 8th plate, there is something called a rebound phenomenon. The 8th plate is holding as a fixed tether to control the valgus. The moment the 8th plate comes off, which is why the end point is usually said as slight overcorrection, the physis stretches out. Now the whole axis, the 10 years, which should accommodate to a certain combination of alignment, you correct it overnight, the body takes a while to kind of reconcile to that. So she bounced into valgus by the rebound phenomenon by the 8th plate. I thought the 8th plate had done the job. So look at that. The problem right now she's having is nothing to do with the proximal tibia. It's the distal femoral valgus. Even though it is picked up, corrected, this is what can happen. So she ended up needing a distal femoral osteotomy because she's finished growth and we had to reef up the MPFL using the adductor magnus tendon. So look at the journey, how it went, you know. So that's corrected. So I got her back to where she was, you know, more damage on the medial compartment. I didn't want to get her into the medial axis, slightly in the lateral. She's 3 years down the line. I think she's now in second year college. When I last saw her probably about a year ago, no issues. She says phenomenal. And I'm just waiting for the next problem to come. Yeah. And right now she's into that age, what you call Hogarth. Hand over gracefully to the adult surgeon. Yeah. So that's where it end up as, you know. So no patellar dislocations. She's now from the time I saw her, she's 10 years down the line. Yeah. She will need a knee replacement, but a lot of the problems is now corrected. She had just one episode. So the journey is a very bumpy road in a lot of these complex situations. Okay. So we touched upon it yesterday, osteoarticular infections. You know, the original insult was at 1 year. The chapter had been closed, you know, they had not even declared it their insurance or whatever. And at 11 years, first symptom, and 11 to 21, multitude of surgeries, different strategies to correct the same problem. Similarly, here is another, this is just to illustrate, this is a shorter course, you know, post-traumatic distal femoral physeal injury. Okay, 15-plus-year-old when he presented, he had a 4 years prior, he had a distal femoral injury. And this is where he ended up at. Again, list out the problem. It looks like, oh, that's distal femoral valgus. There is a leg length discrepancy, a significant discrepancy. The extensor mechanism is sublux, the resting position, the patella is out and the knee is straight. And that's because the quadriceps is short. And you cannot, when you hold it down, you can't. The quadriceps doesn't have enough excursion to allow knee flexion if you manually reduce the. So that's something what you correct it, you may still need to do procedures to address that. So there are several strategies. You can stage it, you can do acute correction, you can do gradual correction, you can do correction, osteotomy, and subsequent lengthening, many options. But each of them will have different problems. If you're thinking about an acute correction for this, the valgus deformity, that's a lot of valgus. You need to think, what are you going to do with the peroneal nerve? Not so much of a problem in the distal femur, but if it is a proximal tibia, you will need to have prophylactic peroneal nerve decompression. So I prefer to do them single stage, try as much as correction as much as possible in one sitting and gradual correction. And this is what we did. We did a fixator assisted correction, gradual lengthening. And fortunately for the patella, all that we needed to do was the Young's procedure, resect the iliotibial band a little bit. And I was prepared to do a quadriceps plastic if needed, as a subsequent stage wasn't needed. This is where we ended up as, again, you know, all of these, I tend to slightly overcorrect. Don't worry about where the angulation is, because don't worry about the angulation of the osteotomy side. That's inevitable. There is translation, and it's always a translation angulation osteotomy if the correction is away from the cora. The cora in this case is the distal femoral physis. I can't correct it there. I've gone further away. As per the osteotomy rules, it will inevitably translate. That's of no consequence so long as the axis is right. Whether you do the osteotomy in the proximal femur or the distal femur, wherever it is, that's osteotomy rules. So moving on to something like this, which is hip. Again, at first looking, it's like complex deformities. This is about a 5-year-old developmental problem, developmental coxa where waddling gait. Initially, the parents thought it was like just simple waddle. By 5, that is significant. You can see gross, especially on the right side. The physis is not at all visible. Again, to reiterate the point, however you choose to do it, you need to plan these. You need to kind of draw your lines, assess the deformity, see what you're trying to achieve. Whether you choose pen and paper, whatever, this is using the Bone Ninja software. You need to see how you want to kind of correct this. You need to kind of plan where you want to kind of put your plates. What plates are you going to put? Are you going to cross the physis and all those kind of situations? Only then can you execute your surgery better. Here we have corrected it. Again, it's an angulation translation osteotomy. The cora is at the physis. I am doing the osteotomy at the subtrochanteric level. It will inevitably translate. It will be an end-to-side opposition. It doesn't matter, Naked. All that you want at that stage is the medullary canal lining up with the piriformis fossa. That's all that you need to. You need to get that anatomy right. And only a straight lateral plate will allow with a subtrochanteric osteotomy. The additional screw is to do a trochanteric epiphysiodesis because the proximal femur physis, the femoral neck physis is not going to grow. Trochanter is going to grow. So I need to stop that, so that is something which I need to kind of test. She's about 6 months down the line, doing well, but again, it's a long journey. The anatomy by no means is it normal yet. There may be other issues to tackle with later. So I conclude with this last case, and I suspect in this forum, there are plenty of you who have harvested a fibula, right? For various reasons, yeah? Here is a 10-year-old boy who's referred by the plastic surgeon to me for pain and deformity in his left ankle. This is the call that he said. He said that I've got a report, I've done the X-ray and the CT scan is told avascular necrosis of the talus. Now I really don't know, top of my head, I can't think of solutions for that. He has had a previous vascularized fibula graft, not the fibula strut that we use, for a desmoid tuber mandibular reconstruction at the age of 7 years prior. Okay, and he's doing very well. The plastic surgeon is quite happy with the reconstruction. These were the pictures that he sent to me on WhatsApp. You can see, the resection segment gone. Unlike what we see with the fibula strut, in a vascularized, because the periosteum is taken away, it doesn't regrow. Okay, there is valgus. Is there a lot of valgus? Bear in mind, this is a non-weight bearing picture. Okay, so that's the CT relevant sections. You can see the lesion in the talus. This is when I saw him. This is what he has. There is clear valgus malalignment of the hind foot, which is not fully correctable because sometimes they're flexible. There's clear prominent medial malleolus. But the ankle range of motion is, you can see some amount when he goes on his toes, some amount of correction happens. When you take a weight bearing picture, you can see clearly difference. You can see the clear difference. See the amount of valgus here. See how it is tilted. That's the normal side. See the station of the fibula. That's the normal station of the fibula. That should be at the level of the joint. Here it's gone above the tibial. So there are a lot of problems happening there. Okay. So interestingly, the parents had gone, they were concerned that some deformity was happening. They had X-rays which were done elsewhere in a different city. Okay, and this is the change between 16 and 20. What's going on here? Okay, have any of you encountered ankle valgus of a significant problem after fibula grafting, John? Yeah. So this is, she's kind of touched upon that, this thing, you see it when you excise it, because then you would take the periosteum away, whether it's a tumor or sometimes you see it after osteomyelitis where it's destroyed. So the harvesting, we leave the fibula periosteum intact and it regenerates. In a vascularized graft, they take the periosteum, they obviously need the periosteum. So this is what, when you plan it, these are the problems that the child is having. You need to kind of see what is happening here. Okay? There is clear, you can clearly see the defect on the anterolateral corner. So we did a little bit more planning. You have to do your hind foot alignment as well, because like everything else, body is trying to compensate. So there is distal tibial valgus, ankle is going into the compensation can happen at the subtalar or the calcaneum. So the calcaneum is going into a little bit of varus. So the body is already trying to compensate. So if you do an acute correction and correct all the valgus, you might end up leaving the child in varus because the body is already trying to compensate. That's the MRI picture clearly showing the osteochondral defect, the size of the defect. So we thought, oh, we have never encountered it. I do a fair bit of fibula grafting, not a lot, but this is new. We looked up, it's well described in the plastic surgery, in the oncosurgery, orthopedic literature, hardly any mention. The morbidity after this is immense after, because they harvest it, especially if they harvest it. It's well described in vascularized fibular graft. When they take the periosteum away, this is something which is fair. Almost up to 25%. That's a significant complication. There's clear description, in terms of what happens. These are the risk factors, especially when you take it in a smaller child. It's been described in our literature as well. I think Professor Babelkar described a long time ago about how much fibula you need to leave, but that is in fibula strut. But when you look at this, so in a 3-year-old, if you were to kind of this thing, you need to leave almost 13 centimeters of the fibula. You can't leave that if you're going to harvest a graft. So it's a high risk. And the sequence of pathologies, this is what happens. Fibula starts to migrate, there's valgus mortis, the talus starts shifting. So one of the theories for osteochondritis dissecans for the talus is because of weight bearing. So all the loading happening there, it starts getting wet. So clear cut, it's well described. It's just that we are unaware of it. I was unaware of it. And they even recommend various things to prevent it when you harvest it, to do things, to kind of so that it doesn't happen. So essentially, you need to you can't say, oh, there is a little bit of valgus, brace it. You need to evaluate and look at it. Okay, so we have a lot of options in terms of how to correct this, to do a corrective osteotomy. Main consideration is only 11. I don't want to do a major osteotomy and have problems later. There is still adolescent growth spurt to happen. What about the calcaneum overcorrection?
I think the hip has been out for a long time. How long?
Exactly, sir, more than 2 years.
Oh, only 2 years. All right. I think probably my aim would be to
Down into position is a very difficult job. It's not easy. And we decided in the place like you people only went
a shaput also here. This is a shaput fracture where the anterior inferior syndesmosis is attached. Generally, an angle of 7 to 21 degrees and on an average of 15-degree angle is made by the posterior malleolus fracture. Hence, if you are taking lateral X-rays, if you do not want the fibula to come in the lateral X-rays and if you want to see the posterior malleolus very clearly before the CT scan, you have to just take the lateral X-rays in 15 degrees of external rotation. 15 degrees of external rotation lateral will show your tibia completely in a lateral and you can identify your posterior malleolus. You need CTs to know your trajectory of the screws and fixation of the posterior malleolus. A posterolateral incision, which is between the peroneal and the tendoacheus, or a posterior medial incision, which is between the FHL and the tibial nerve. And this is one of the cases, an apex extension of the posterior malleolus. There the fibula is not there. You can see the X-ray, you can see the CT, take a posterolateral incision. And in one incision, you can fix both the posterior malleolus as well as the fibula. Put a posterior plate on the fibula. It's enough. Once you do that, you have done your posterior malleolus, you get good ankle syndesmosis stability. This is another case wherein you have the posterior malleolus. This is a, you have a long beak over there, so you need to buttress that fragment. You go down and buttress and put a posterior fibula plate. This is dislocation, and you can see these are common injuries which you get a posterior malleolus there on the CT, and you put a small buttress plate, fix your posterior plate on the fibula, and you're done. So it's not a very difficult one. The double shadow over there, and you can see this is the type 2 one, where it's a posterior in lateral as well as a posterior medial fragment over there. So you need to know, you have to go down now posterior medially. How you go down posterior medially? Ideally, it is two plates like this, but you can go away and put a posterior medial incision between the FHL and the tibial nerve, and you may opt for a single plate also, or a screw and a plate for the other fragment. Now, this is a posterior medial fragment over here. Here, the CT shows this is posterior medial extension on the medial side. Go down parallel to the Achilles on the medial side. Identify the FHL and the tibial nerve, go between the FHL and the tibial nerve, and you land down on the posterior malleolus fragment, and you can put a initially fix with K wires, C for the reduction. You'll get a good reduction. It is very easy to fix from there on the posterior side. And this is the plate, you fix it, and you have done your job after your fibula fixation. Another case, this was a long time back when we were not using plates. These here we had these this posterior medial type of a fracture, and we went ahead and did this CT, again a posterior medial extension. We planned it, and we planned for 2 screws. Initially we used to put only 2 screws, but mind you, if you're putting 2 screws only, you put with the washer so that it acts as a single hole plate. There it was with the washer, and we could. Restoring your ankle articular congruity is very important. Increasing the rotatory ankle stability and providing a bony restraint against posterior translation. Posterolateral fragment there, it's a small fragment, and one single screw with a washer we could get away with. Whether you're going to fix anterior posterior or posterior anterior. This was a controversy, but now things are very clear that you have to go posteriorly. You can't lag your posterior fragment from anteriorly. So because posterior anterior fixation, you go down, you visualize the fragments very well, and your posterior ankle anterior fixation gives you a better result. Hence, there is no compromise to your joint congruity and fixation. 25% posterior malleolus gives a 4% reduction in the contact area. 50% will give you 22% reduction in your contact area. Summarizing, I would like to tell you that syndesmotic stability via the PTA, the posterior inferior tibiofibular ligament fixation is very important, and then the fibula goes inside the incisura. Tibiotalar congruity is maintained and the stability is maintained. CT needs to be done for all these fractures. There is no doubt. You can't go ahead without a CT. Posterolateral and posteromedial. You need to plan which incision, how, and the antiglide fixation or just simple screws with a one hole plate. That's a washer. Okay. Thank you.
Nice presentation. And for our next presentation, I'd like to call Dr. Sudhir Kumar to talk about reconstruction of TA and how to deal with the complications.
Good morning to everybody. My topic is the tender Achilles reconstruction. It's nice to know, nice to do the tender Achilles reconstruction, but once you are going to face the complication, how to deal it, that is equally important. Manage the rupture, but be ready for the complications. It's a palpable tendon defect, inability to do the range on the tooth. Thompson squeeze test, metal test, and O'Brien needle test are important to evaluate about the rupture of the tender Achilles. X-ray, sometimes you are going to see the bony spur, the calcification of the tender Achilles, and occasionally you'll be able to realize about the soft tissue bulge or soft tissue swelling around the ankle joint if you are going to get a right kind of X-ray. Ultrasonography is significantly diagnostic. MRI occasionally you do require to go for. Non-operative treatment is suggested for the rupture of the acute rupture of the tender Achilles, and sometimes this is applicable to get rid of the problem. But most of the time you do require the operative treatment, which has got a lower re-rupture rate, but has got a higher complication rate, and good reports reported with open or percutaneous and repair techniques too. People who are having the chronic tender Achilles rupture, augmentation, fascia lata with the fascia lata tendon graft, facial advancement, tendon transfer, synthetic or allograft augmentation may be indicated. These are the contraindications like the arterial insufficiency, poor skin and soft tissue quality, poorly controlled medical comorbidity, inability to comply with the post-op rehabilitation, tobacco, senior citizens, sedentary lifestyle, obesity, with obesity. So these are the contraindications. Whatever contraindications are there, many times we are compelled or we feel to do the surgical intervention in some of the cases. Here, one of the patients who is having a rupture of the tender Achilles following the injection around the tender Achilles. You can see the dipomedrol deposits here. So this is one of the patients where be careful about the healing of the wound after doing the repair of the tender Achilles rupture. Patient, we have removed the part of the hood lung deformity, fixed it with a single suture, and patient has healed well. Although it's always scary to get the problem like this once patient is having a previous history of injection around it. Another patient, you can see the defect or some palpable defect is here, tender Achilles. This was a rupture through the upper part of the tender Achilles, and obviously repair is simpler here. In a person who is highly active, usually the senior person, they are having a rupture like this. He's a doctor and a sportsman too. While playing high sports activity, got a rupture, and the fibers are like this. How we are going to repair it? All fibers were collected together, repaired it, and was augmented with the plantaris. I do leave the plantaris attached distally and harvest it from the proximal wound, and do the weaving with the help of the plantaris. That is going to augment it. One beautiful thing about the plantaris, you can spread it like a sheet of the paper, and you can wrap around the site of the repair of the tender Achilles. Another example is like a fracture through the calcified part of the tender Achilles. So you have to remove the calcified part and do repair at the site of the insertion. Another example, patient having a large gap, old tender Achilles repair, did a reverse kind of slap or raised, made a tube, reinserted it back. Another example, but here, this is the result. You can see a small amount of puckering. So this is a kind of complication you can expect occasionally in cases of after the repair of the tender Achilles. Another example, one more example, just like that. I do prefer to make a tongue-like flap from the tender Achilles, reverse it back, make it a tube, and augment it usually with the plantaris. They are going to have the good amount of the tube present at the site of the repair. A patient with a large hood lung deformity with a retrocalcaneal bursa with a large gap. They do require the excision of the both of the bursa as well as the removal of the calcified of the part of the tendon Achilles. The same patient underwent through the surgery. One can achieve the leveling if there is a small amount of the gap. One can do the VY plastic proximally and pull it down. Especially once you are going to do the tibialis posterior transfer, you want to weaken the posterior structure to some extent. One can do the aponeurosis relief like this to improve the strength of the tibialis posterior muscle after the transfer. Complication may be infection, scar adhesion, skin necrosis, tendon lengthening, or re-rupture. So one must know how to deal with these complications. Very scary to see this small part of the suture is coming out of this. If you are going to pull the suture, is it going to solve the problem? Definitely no. Sometimes you like to give the specific antibiotic. It's not working as the bone is infected. And secondly, the whole tendon is getting necrosed here. So it's very difficult to treat the condition. They do require a radical debridement and occasionally the removal of the complete suture and resurfacing indicated. A defect here, very difficult to get the healing. So we did a reverse flow sural neurocutaneous flap to cover the area. One more example, large defect was covered with the sural neurocutaneous flap. Debridement and again coverage with the help of the sural neurocutaneous flap. This is one of the flap, just to show this flap, although the defect is here, very small defect is here and mobilization is impossible. So we did a medial speedy artery flap, harvested from the navicular, rotated it back to cover the area. This was beautifully covered and you can rotate the same flap to cover the defect like this with the help of the medial speedy flap. Another example, a compound injury with a defect covered with the same kind of flap. The result on the long-term basis, a patient who is having a defect here, occasionally you are going to see the defect at the site of the insertion of the tendon Achilles. Although this muscle flap is very small area of arc rotation. This is abductor hallucis muscle brevis flap. We can rotate it to cover the medial malleolus, to cover the part of the distal part of the tendon Achilles. So this is a useful flap, muscle flap, but arc of rotation is very much limited. There is no significant compromise. This is one of the horrible conditions you are going to see in day-to-day practice. Whatever careful are you, but occasionally you are going to see the exposure of the tendon Achilles along with the exposure of the calcaneum after the reconstructive surgery. Was covered by using the lateral supramalleolar flap for the area. A patient who was a diabetic, hypertensive, and senior citizen was having a defect like this after the reconstructive surgery. So we have rotated the lateral supramalleolar flap to cover the area. Another example, a perforator based flap which can be rotated to cover the area. One more example where you can use the extensor digitorum muscle brevis flap to cover the tendon Achilles or a defect around the heel or calcaneum. One can use even a dorsalis pedis artery flap to cover the defect around the heel, ankle, or tendon Achilles. Cross leg flaps are simple, reliable, and any day anybody can do it very comfortably. You need to have a kind of orientation. For me, it has to be performed carefully, must have the knowledge to manage the complication, and you should have the courage to refer the patient to a suitable person. Thank you very much.
Thank you, sir. Next topic is calcaneum fracture. So please, I'll call upon Dr. John Mukhopadhyay. John, sir.
So I'm going to talk about calcaneal fractures, and hopefully at the end, if there's some time, we'll do a sort of one case for the experts like Mahinda and Rajiv around. Okay, I think so. We need to be able to assess these fractures carefully and plan your treatment strategy according to what you find in your investigations. Remember, these fractures can end up in trouble, and the literature is full of comments from experts on the bad outcomes following calcaneal fracture. You have to understand the mechanism of injury, which is usually an axial loading, and that's the primary fracture line you see. And then you get the various secondary fracture lines going across here. And the effects end up with shortening, broadening, sort of a loss of height, and subsequent impingement and arthritis, which are the problems that you deal with, malunited calcaneal fractures. Okay, so all these problems which you need to look out for before you plan your treatment. I think the CT scans again are essential here, and a classical example to show you the importance of this is this X-ray on this patient, which if you look at, looks fairly innocuous, but if you do the relevant CT scan, you can see the clear depression in the posterior facet, which tells you that you need to do something about it. I think the classification again is known well to you. You have the Essex-Lopresti classification, which divides it into the tongue type and the joint depression type of fractures. But today it's the CT-based classification of Sanders that you really need to look at in terms of doing your reduction and fixation. I think the classical operative approach is using a lateral extensile approach. The incision today has gone more posteriorly towards the TA and right down to where the sole and dorsal skin meet. And this is based on the vascularity of the lateral hindfoot. Okay, so it's important that when you do your surgery, you wait till the skin starts to wrinkle. So the classical wrinkle sign, and this could take as long as 7 or 8 days or sometimes even longer. But you need to try and do your surgery within 2 to 3 weeks because the calcaneum tends to unite very quickly. So that's the incision. The important part is raising the skin flap. I think you really need to go on the bone to make sure you don't have any sort of thinning of the flap here. You need to identify the sural nerve if you're doing the lateral extensile approach, and this here appears in the corner here. And you can see how the entire flap, you don't even see the peroneal tendons. If you can manage that, that means you've been able to raise the flap well. The other thing is this lateral wall. You need to usually remove the lateral wall to be able to visualize. This is not the same case, but here you can see the lateral wall has been removed, and you can see the clear-cut depression in the posterior facet. And if this is a tongue type, you can do it with a shank screw. Otherwise, you need to actually sometimes remove this fragment and de-rotate it. You can use a shank screw with a tongue type, as I mentioned, and then get this fragment underneath the posterior facet, underneath the calcaneal, the talar facet to get a good reduction. And that is critical, your reduction. You also need to correct the varus of the heel if there is any. So classical example, here's a patient. You can see the kind of displacement of the heel, the articular facet as well, as you can see here, is gone right down. So you need to reduce this adequately. And if you're able to do this, you're able to plate it adequately, you're going to get a good result. This is him in the follow-up X-ray and his clinical function at the end of 1 year. However, one of the problems with these extensile approach are the wound problems, which you need to be aware of. And therefore, today, we've gone on to less invasive approach, either percutaneous or the sinus tarsi approach, which are suitable for the less comminuted and displaced fractures. So here's an example. Again, this is a tongue type. You can see the depression here. Here we've used a sinus tarsi approach, used percutaneous screws to fix it, get adequate fixation both of the facet and the calcaneum. And this is him literally 2 weeks at the time of stitch removal, mobilizing. And you don't keep them in cast for a long time. That's the other important thing. Here's a bilateral calcaneal fracture, where one side we've done a percutaneous fixation, and the other side we've used the sinus tarsi approach and fixed with a plate. Here's the lag screw which goes across the posterior facet, the plate, and this is his post-op X-ray. Follow-up X-rays, you can see again good correction of varus of the heel and the articular surface, and a reasonably good function at the end of it. One more mention is about the tuberosity fracture, and these you have to be careful with because they can cause skin problems. So you need to get at these quickly. Otherwise, this fragment very often will come out of the skin and then you have a big problem. So you need to reduce them. They need open reduction. They need a bit of effort to reduce, but you need to reduce them and get adequate screw fixation so that you can start them in reasonable early mobilization and go on to heal well. Okay, so the take home, I think, is the treatment depends on the severity of injury. The timing of surgery is soft tissue dependent. You need to do meticulous soft tissue handling to prevent complications. And articular reconstruction and reduction of the calcareal body gives the best results. So that's important. I think I still have a couple of minutes, so I'll go on to this case. This is a 39-year-old who presents 3 months after injury and complains of pain and limp. And these are his x-rays. So Rajiv, that's for you, for the experts. Would you do something at 3 months or would you leave it alone?
What is the patient?
Limp and pain on walking, basically. Got a mic there.
What is his profession?
He's a manual worker.
He's a manual worker. So that is very important. But still, it is just, so he's got a pain in walking. As far as alignment is concerned, I don't have an axial view, but it looks reasonably good alignment.
There's some varus in the axial view, but not too bad.
That's
The main part was the articular depression.
I will still tell him to carry on till he is exhausted. The
Yeah.
moment he is exhausted, that he doesn't go on, then I'll go in for a CT scan. At this point, the calcaneocular looks fine to me, and talonavicular looks fine to me, and then I can think of the subtalar arthrodesis in this case.
So,
But I would leave on the patient, keep on, telling me if he's exhausted, then only he should come.
yeah, this is 3 months old.
3 months, it's a 3-month old.
Yeah, so I think I agree with you there, but we've started doing some of them on the later cases. So 6 weeks, 8 weeks, then this was at 3 months, which is the limit we've gone up to. So we decided, so those were the CT scans. Okay, so we did so there's some varus on the heel, not too much. That is the depression there. So if you leave it, he's going to end up in arthritis. The chances are very high. So we thought whether we can at this stage still do something. So the standard exposure, then you can see that. So it takes time to find out the articular surface. You have to nibble out bone, avoid damaging this articular area. And then we planned our osteotomy. So we did the osteotomy, kind of taking this off like that, and then de-rotate it, get it under the talar surface. Also try to correct the heel to some extent with the shank screw. Put in our lag screws across to the cystinacular fragment and plated it. And this is post-op X-ray. You see, we've been able to reconstruct the joint reasonably well. This is him 2 months post-op, and this is him at 1 year, 4 months post-op. So doing quite well with a reasonable joint space even at this time. Not perfect. We don't expect perfection at this time.
I think this is a very good point here to make, that this, even at 3 months, you try and attempt and get as much as possible, because eventually tomorrow, if you need to do a subtalar treatment, it's going to be a cakewalk. That's very important. So even a late reconstruction, a bad looking subtalar joint, not all bad looking subtalar joints are painful. For some reason, they all do pretty well, just like an ankle joint also. So don't be a little bit defeatist, like go inside and try and get that facet up, correct the calcaneal length, everything, whatever you can do. And eventually, if it does get a painful ankle, then you can do a septal fusion, which is a really easy thing to do.
Yeah, but I think it's important that you choose your cases carefully. This guy had a clear-cut, nice facetal area and not too much combination. If it's really shattered, then I wouldn't try
Primary fusion.
Yeah, then I would go on to a fusion. But if you have this clear-cut delineation of the joint and a single facet, even at this stage, we can do an osteotomy, get it round and correct it, and hopefully get a reach. So we've done now 3 cases which are later than 6 weeks old. So I think it's worth trying to do this. Thanks.
Yes, sir. It's definitely worth trying, but whenever I take patients, I always tell them on the table, if I find that joint is not good, so probably I may go ahead with arthrodesis at that time. I know the platform has been made very easy for us by the previous speakers, and calcaneus, posterior malleolus, all these fractures have been pretty well discussed. So and John sir is here, so I think that thanks. So so we are continuing with calcaneus, sir. So I would like to have your opinion now. Okay. I have different cases. I don't know. So it is just the continuation of the previous three talks, what I had. So I have number of cases. Whenever you want me to stop, sir, please. Let me know. So this is for you, sir. That's all. So 32-year male operated 1 year back. So for fracture calcaneus, someone did a sinus tarsi approach, and now the pain in subfibular region, there is tenderness in that calcaneal cuboid region is also tender, and there is extreme limitation of the extreme dorsiflexion, and there is pain in the insertion of the tendoachilles. So this is how the pain, if we see the already scar is already there, and this is how the CT looks like in this. So you have an implant which is in the lateral wall, and then subtalar arthritis, you have cuboid arthritis, decreased talar declination, and heel boss, and a previous incision. So, sir, anyone, what we should do? So we have multiple problems. Now in malunited fractures of the calcaneus, when we look, we want to see what are the pain generators in it. So just don't go with a subtalar arthritis. We need to find the pain generators in this. That was the whole idea of bringing this case. So any suggestions about how to go? There's already an incision in the sinus tarsi. So that is making the things very complex, because going through the flap, it will be difficult. So, and then we can, so any suggestions, or should I go ahead with?
Yeah, so I think this is the important part, is when you're doing the arthrodesis for these malunited calcaneum, it's not just the joint that you have to think about. You have to think about the impingements, the calcaneal height, the varus valgus, whatever deformity is, and you need to correct all those apart from your arthrodesis if you want to get a good result. So I think that's very important that you brought that out.
So that was the basic message which was to be conveyed. Now the problem was, now do we use the same approach, or we use any other approach? Dr. Mendra,
See, I think you could probably address all the issues using the same incision, because all their pathology is on the lateral side. So you can address the calcaneal cuboid joint, you can address the lateral fibular impingement, and also the bossing. So I think use the same approach.
and so, you know, we extended this approach a bit and went anterior to the peroneal, and then also posterior to the peroneal. You can see the screws here, which we removed, and then we went into the subtalar joint, and this is the heel boss which was causing the problem. So we excised this heel boss which is causing the problem. Then we did all, so there was anterior impingement. So we went on to do the distraction at this place, put a lot of graft into it, and then we fused all the joints in this, and even the calcaneo-cuboid joint, because he was having the calcaneo-cuboid problem. So this is what actually we did. So the idea of bringing this case was, you should look into all the pain generators in these patients before going, and this is what happened later on. Okay, this is another way. This is not my case of doing such. Some people are doing through the posterior approach these things. So this is another way you can do. You can go through the posterior approach. And this is what I wanted to say, that these are the pain generators in the malunited calcaneus. So you should have look at all the things. Okay. Yeah, ADNEI classification. There's
Adenoma.
Okay, I can show that also. Okay. this is another case. This is just a continuation of the talk on the posterior malleolus. So, malleolar fractures and RTA, 37-year-old male, and we had road traffic accident, no associated injury, and this is the CT scan of that. Dr. Ajit, this is your, sir, this was your posterior malleolus stock. So there's some, and may I go back? So 37 male, no complication, nothing, and no associated injury. This is no medical comorbidity. These are the CT scans. So if you look here, this is what you showed. I think it is exactly your case. You have a more of a posterior sort of a malleolus. So this is the, so we took a posterior approach, posteromedial approach. What I tend to do is if you have there is a vertical fracture also. If you see now, you need a medial buttress also on this. So if you go a dead posteromedial, it may become little difficult. So that is what was the idea of bringing this case. So I just use this approach. I hope I have this approach here. Okay.
This basically the posteromedial fragment was continuous with the medial malleolus.
Yeah. So I went a little, on the posterior aspect of the
routinely taken medial malleolus.
So went between the flexor digitorum and the tibialis posterior. This is what I'm doing it. So here, this is one where you can address both posterior as well as the medial malleolus. You can do the buttress. So the idea was now you can go to even the medial malleolus side and you can fix it. So this is how we ended up, both the incisions in these cases, and this is how the fracture looks like. Okay. Dr. Mendra, if you want to add something, please.
No, this is fine.
So
That's straightforward.
this is interesting. Okay, I'll take this case. There's so many of them. I don't know. If you see here, this is an interesting case where I struggled, and this happens to be my mother. So this is my mother's X-rays. So she got a TKR done around.
Just wait. Not coming.
Okay, so this is my mother's X-ray. She got a TKR done at our place at 72 of the age. She's a diabetic, and then I made her walk, but after 3 months of TKR, she started complaining of pain in the foot. So I just went and got an X-ray done.
Which side of the foot?
Which
side of the foot? Which side of the
midfoot?
midfoot?
Midfoot pain, and it was diffuse midfoot pain. So anyone can figure out anything in this X-ray. I couldn't figure out. So I just treated her with a few analgesics and good brace and all that. So, but she did not. Okay, she had a pain more on the medial side.
Medial side.
Yeah, she had no.
The talonavicular to me really looks a little.
So I also made all these wild guesses, and then what happened? I just got an MRI done. I got fed up with me that I cannot make the diagnosis. So it was a stress fracture of the navicular. Normally, you get the stress fractures in the athletes. Yes. It's a very rare to get a stress fracture of the navicular at this stage. And I don't know, but all I had to do was, this is some literature about mostly in athletic injuries. All I had to do was immobilize her for just 2 to 3 weeks, 2 to 3 months, and she went on. So actually, okay, I take another case. So whenever, sir, you want me to stop, I have ample number of cases. Okay, this was you were generating something.
Just wait, Rajiv, it's not coming on the screen.
Yeah, yeah. So this is
Rajiv, it's not on the
again-
screen.
No, I'm coming. I'm coming. So this is a polytrauma patient with us, and 2 weeks old foot injury we had to, because initially we were busy fixing ankle and spine, and then we were left with this sort of injury, and this is how it looks like. And now there's a lot of controversies whether arthrodesis or what it is. So
Was there a significant soft tissue swelling or a compartment?
yeah, now just 12 days down the line, everything is settled. Now it's the patient is ripe for the surgery. Now the only thing is what we are going to do in this. Are we going to salvage the joints? Are we going to arthrodese the joints? What level there? Any comments from or should I proceed? What we did in this case?
So at 12 days, I would still try to reduce it. Obviously, plate the medial part and KYs maybe for the lateral part of the injury. So depending on the injuries, we sometimes fix with screws or we put a bridging plate depending on how across to the metatarsal, depending on how bad the injury is.
Thank you very much, sir. So you see, this is a strange sort of injury. There is nothing happening on the first TMT joint. That was the idea of bringing this. You never know in these cases where the forces can travel. They can travel through the intercuneiform, right through the navicular into this. So you should always keep in mind when you are doing a Lisfranc injury, never forget the intercuneiform and the proximal parts. So the only idea of bringing this case was this, to convey this. So at 10, as John sir said, we wanted to salvage things. We brought everything in position, and first intercuneiform instability was tackled, and then we pinned the second metatarsal to the middle cuneiform. Once it was okay, this intercuneiform instability, then again we removed it and fixed a screw, which is what Vinod Panchbabi says, you go from the second metatarsal to cuneiform, then going from cuneiform to the second. And this is my routine in most of the cases, which I am doing. And then we spanned a plate from up to navicular also in this case. And then we found that even the third was unstable. So we went to do the third, TMT. And this is how the incisions looked after. And this is what, okay, now maybe I have time for how many cases? Okay, one case. So another case, this is something like for everyone, I would say, this case is there. Important? No, I don't want to remove the plates. I don't want to remove the plates unless they are troubling. People come to me after 2 years, 3 years, sometimes the screws back. So they are irritating the tendons. Only then I remove it. Otherwise, I don't call them for formal removals of the implants.
Because you haven't fused the joint. So
Yeah.
then you have to think about the implant kind of considering it and warn them about the for removal there.
Although it's a whole joint, 3 joints which are sharing each other loads. And so I haven't seen much of plate breakages in my practice in these. But if they break, if they have any problem only then probably if they break, they are having instability. If they break, they are having. So plates are there to create an environment to stable the joint itself, the ligaments to heal to everything. Once they are healed, probably their function is gone. So if they are there or not there, it doesn't make any difference. And if they are breaking and the patient is having pain, you are removing it, probably you will need a fusion. Probably you will need a fusion. Okay. No, if there's an implant is broken,
If it's a purely ligamentous injury,
Yeah.
then you would do it on stage 1.
No, I still feel the joint should be preserved, whether it is a purely ligamentous injury, at least 6 to 8 weeks. And if after 6 to 8 weeks, only I think of fusion, I want to preserve my joint. Our previous problem was we were using the transarticular screws. They were causing a lot of damage. Now we are doing extra articular platings. Then why do sacrifice?
And
the
actually,
joint?
all the studies of fix or fuse, the problems are only with hardware removal and secondary sometimes pain. Otherwise, OFS scores are good in both the cases, so it doesn't matter.
Okay. Okay. I'll go to the probably the last case, or whatever the chairperson said. So this is the case. We had a fracture on the both sides. On the one side, we had a segmental sort of tibia, and the other side, the compound ankle injury. And we just plated this tibia on the one side, long plates, and the other side, there was nothing around, so we just attempted a primary arthrodesis, try to get everything aligned in the fixator. So 7 days post-op, this thing happened. So then 14 days post-op, this thing has happened. So this is the mistakes I have done. So probably I'm sharing my mistakes. So I just said that how to learn. And then we kept on doing the debridement, and this is what we had after 4 weeks of the post-injury. And then we thought we are great surgeons, and let's go call our plastic surgeon and do some microvascular flap. So a microvascular flap was done to preserve the limb, and this is the state of affairs after that flap. And this is how it looked like after, let's say, 2 months post-op. So 2 months post-op, this is the state of affairs. Now we have debrided everything. We have a flap, and then there was a big gap. Okay, so this is the state of affairs of the limb. This is what is happening to the limb. Then we thought we'll do another surgery, and then started distraction osteosynthesis in this. Yes, we got the regenerate, while the other side got union, and we could get the regenerate. So this was the regenerate we got, and what happened then again, it fractured. It again fractured. So we didn't leave this case. So we kept on doing things, and then we played on this patient. So end of the line, this is what is the patient is. And yeah. So I don't know whether we have done anything right for this patient, or this is better. While doing the course of the treatment, we should have opted the patient for amputation. Just telling that we are very skillful people, and keep on doing the surgeries and surgeries and surgeries. So the message was what has changed in the practice. So we need to discuss with the patient whether foot is expected to be salvaged or needs amputation. And there are high rates of primary and secondary amputations. So in these cases, so we try to convince the patient and the attendants, if during the course of the treatment, if you think that this foot is not going to give function to the patient, please don't hesitate to accept that he needs amputation. So anything else? I have more cases. Anything?
Just have a small thing to say. Thank you, Rajesh. It was a very good case discussions. First, I would like to say that it has been a fantastic conference. I'm leaving very early now, so thank you very much, Amulya, for having invited us here. And I hope the foot and ankle guys have made some impact on your thinking. I would like to welcome all of you for the GOFCON in Calcutta. Please register in large numbers and become life members of this association so that it can grow. My secretary, Shantanu, is in the hotel. He's not feeling too well, so he just asked me to excuse. He has some stomach infection, but he's doing better now. Thank you very much.
Thank you very much, sir. Dr. Rajiv got two books of foot, ankle and foot. So he would like to present to Medical College. So I do bring Dr. Professor S.N. Saraf, sir, for the Banga Medical College. May I request you to kindly receive a book from Dr. Rajiv Vora, and he will be presenting it to Dr. Yeah, yeah. And one to Professor
come to
Manish
end of
Kumar
the
for
ankle
Indira
session.
Gandhi Institute of Medical Sciences.
Thank you,
Please, please.
chairpersons. We come to end for foot and ankle session. Our next session is arthroscopy session.
This is for IGMS. Thank you very much.
Thank you, Dr. Mulya. It was a wonderful coming here. Wonderful hospitality. Enjoyed after full 1 year in person this conference. Thank you, all of you. Thank you very much for giving this importance to foot and ankle.
Thank you, sir. For our next session is arthroscopy session. I'd like to moderate the session. I'd like to call Dr. Kundan Singh.
Morning, everybody. For the next session, I'd like to request Dr. Alok Mishra sir and Dr. Noor Akhtar sir to chair this session. Dr. Jivendra Chaudhary sir. Dr. J. Chaudhary sir, please come on the dais. Dr. Dinesh sir, please. Unfortunately, Dr. Rakesh Chaudhary sir is not here for his talk. For first lecture, I'd like to request Dr. Manish Kumar sir from IGMS Patna. His topic is role of peroneus longus graft for ACL reconstruction.
Good morning. I hope this topic is of interest to all the orthopedicians who are interested in reconstructive surgeries. And I think this topic would be a bit controversial also. But this peroneus longus tendon graft is being used as a new arsenal in various ligamentous reconstructions. So before we discuss about the various aspects of peroneus longus tendon, let's have a few glimpses about the commonly used grafts today. Among the most common grafts, there are hamstrings and the bone patellar tendon bone graft. The other alternatives can be forceps, fascia lata, iliotibial band, and of course, peroneus longus. Now, each graft retrieval techniques have got their own merits and demerits. As far as this graft is concerned, and if we compare about the various grafts and the native ACL, the tensile strength of native ACL is around 2000. And among the grafts which can be taken, the bone patellar tendon bone graft has got the strongest tensile strength. The quadruple hamstrings, they have got a tensile strength almost double of the native ACL. And similarly, the double peroneus longus graft, it has got a comparable tensile strength with the quadruple hamstrings. Studies have shown that if the graft diameter is around 8.5 millimeters, the chances of revision rate is almost 1.7%. The risk of revision ACL, suppose the graft thickness is taken between 7 to 9 mm, with every 0.5 millimeter increase in the diameter, the risk of revision ACL reduces by almost 0.82 times. Now, what can be the outcomes after hamstrings harvest? One is high hypertrophy. What does it lead to? It can lead to reduced hamstring strength, especially at deep flexion angles. And we know that hamstring has got a prevention action against anti-translation of the tibia. The hypertrophy can also lead to an imbalance between the quadriceps and hamstring, which can lead to imbalance in the dynamic knee stability. The other effect can be hypoesthesia or anesthesia, which can be due to damage of the infrapatellar branch of the saphenous nerve. The anterior kneeling pain, which is commonly seen with the bone patellar tendon bone graft, which is around 31%, but in few patients, approximately 6%, this can be a possibility. So it is still a concern in patient population where the daily habits involves kneeling multiple times a day. So the anatomy of the peroneus group of muscles, if they are considered, the both of them originates from the posterolateral aspect of the fibula and the fascia of the compartment. It runs over the posterior surface of the fibula tip and the brevis line next to the bone. These tendons are kept in place by means of shallow groove on the posterior fibula, the superior peroneal retinaculum, and the fibrocartilaginous lip, which deepens the groove. On the lateral surface of the calcaneum, the tendons run superficial to the calcaneofibular ligament and the talocalcaneal ligaments. And distal to this ligament, it runs into the peroneal trochlea, which is protected there by the inferior peroneal retinaculum. The insertion, if it is considered, the peroneus brevis inserts on the infralateral aspect of the tubercle of the fifth metatarsal, whereas the peroneus longus makes a sharp turn and enters the fibro-osseous tunnel under the cuboid and finally gets inserted on the plantar surface of the first metatarsal. The actions, both of them are plantar flexors and everters of the subtalar and the mid-tarsal joints. As everters, their main opponent is the tibialis posterior, whereas the peroneus longus, in addition, plantar flexes the first metatarsal, which is opposed by your tibialis anterior. So if a peroneus longus graft is taken, it minimizes the complications associated with the graft used around the knee. And of course, it has a tensile strength similar to the hamstrings. The possible complications of peroneus longus graft can be ankle instability, decreased flexion strength of first ray and ankle eversion. The study conducted by Bunch and others showed that the first flexion strength of first ray and ankle eversion was reduced significantly, but there was no instability of the ankle. In the study conducted by Bunch, the technique did not use the suturing of the distal stump of the peroneus longus with the brevis. So the advantages of the peroneus longus graft can be a larger graft diameter, simplicity of the technique of harvesting, minimal donor site morbidity, synergistic action of the peroneus longus and brevis, and some studies have implicated that the peroneus brevis is more effective inverter, justifying its harvest. There can be some donor site morbidity as per Anton and others who suggested that there can be a reduced peak torque eversion, decreased ankle functions, and concerns about the ankle stability. If a CLR is performed with peroneus longus autograft and a 1-year follow-up was taken into consideration and by IKDC or Lizom scoring, it is seen that it is almost comparable with the hamstring graft, with advantages of larger graft diameter, less high hypertrophy, and excellent ankle function, which is based on AOFS and FADI scores. So advantages. So ultimate assigned strength of double peroneus longus and portable hamstrings are almost greater than the ACL, and if both of them are compared, then it's quite comparable. During harvesting, a skin incision is given 2 to 3 cm proximal to the lateral malleus, and the level of division that is around 2 to 3 cm proximal to the malleus. The distal part of the peroneus longus is sutured with the peroneus brevis tendon by end to side method, and it is stripped off with the tendon stripper, taking care that it should be stripped off about 4 to 5 cm distal to the femoral head, because that can lead to peroneal injury. So if you're not careful, you can end up with this, a CPN injury. So outcomes can be no significant difference between the square hop toss and plantar flexion peak force. Harvested limb has got a significantly less peak eversion force compared to the contralateral limb, but there is evidence of tendon regeneration which is observed in all the patients by MRI, and the total bilateral peroneal tendon index was around 82.9%, which is quite good. So ankle functions, they are evaluated by AOFS and FADI scores. The mean AOFS score was found to be around 97 and FADI was 98. Both of them are good results. So the above result shows that the function of the donor ankle was excellent even after harvesting the peroneus longus tendon. And this is probably because peroneus brevis is still intact. So peroneus brevis can be considered peroneus brevis which is intact, that helps in retrieval of the peroneus longus graft. So the take home message can be the Prentice longus is an appropriate aptograph for ACL reconstruction because of the ease of harvest, adequate size, cosmetically appealing, excellent post-operative knee scores. It has got no effect on gait parameters and does not lead to instability of the ankle. Thank you.
Thank you, sir. We all know PCL is main stabilizer of the knee joint, and arthroscopic PCL reconstruction is a very tough job. I'd like to request Dr. Rajiv Raman sir for his talk on arthroscopic PCL reconstruction.
Thank you, Team GOFCON, Amulya sir, and Manish Arvind for invitation. So I will be talking on PCL reconstruction deep and fix. As you know, it's one of the important stabilizer of the knee, and arthroscopic reconstruction has very good predictable result. And if you get the patient, you can see here, classically, most of the patient comes with a positive set sign, and you can see the posterior dot is positive. It suggests that there is some posterior instability. So in these cases, the only option is either open or arthroscopic PCL reconstruction. Nowadays, we are doing more of arthroscopic PCL reconstruction than open. I think this is so once you put your scope inside, and you will see the classical lax ACL. This is a telltale sign, or sagging ACL. We call it the SFACL. It's a telltale sign of PCL insufficiency. And you will not get a empty fossa sign. What we get in ACL deficient knee, when you have a empty fossa sign over the medial aspect of lateral femoral condyle. And the first and most important step is way to the removal of the posteromedial femoral attachment, and try to preserve some of the ligament, and then you will have way in the posteromedial compartment. So once you go in the posteromedial compartment, the first and most important part is making of the posteromedial portal. That is the key portal, because the whole of the PCL reconstruction depends upon good posteromedial portal. Try to make it a bit high portal, and your needle acts like your guide. Over that, you make a small nick over the posteromedial capsule. And once you have made a small posteromedial portal, then pass your switching rod over that, pass your cannula. And that is your main portal from which you will save the posterior remnant. You can manipulate the intercruciate interval also. So once you have made the posteromedial portal, you can see here I am switching the cannula in the posteromedial portal. Now with the saber blade, try to debride the posterior aspect of the PCL attachment. You can see here, and you should make a good release on the posterior aspect so that the end point is when you can see the popliteus muscle. The red popliteus muscle, once you can see that popliteus muscle, yes, that should be your end point. And be cautious here because you are very close to neurovascular bundle. Always try to put your saber blade towards you, towards the tibial surface, not towards the capsular side. And now put your PCL J. The most important part is never try to put the PCL J in the superior part. It should be at least 15 millimeter below the joint line. Here you can see, and the marks are there over the PCL J. It's almost 15 millimeter below the joint line. And once you have placed your PCL, and you can see here, the 15 millimeter mark is there, and I can see the joint line. You pass your breathing. So your breathing should go at least 15 millimeter below the joint line. Over that breathing, you should make your drill. And you can see here, now your jig is acting like a protector, and over that between, I am leaning from the anterolateral surface of the tibia towards the posterior surface. And that should be under direct vision because these neurovascular structures are just 10 to 15 millimeter apart from your PCL. So once You measure your graft, suppose your graft diameter is 9, 10 or 11. So you should remit with the desired diameter cannulated region. So be very careful in this step because this is very crucial step and always do it under direct vision. And you can see here, once your drill is going towards the second cortex, you can see here, because of the negative pressure, the whole of the big pin will come inside. And now pass your suture lasso from the lateral aspect of the tibia towards the posterior aspect. You can see here, the suture lasso I have passed from the posterior over my big pin. And now park the suture lasso over the posteromedial footer. And you can see you can use a probe or you can use a suture passing device or you can use your grasper also to park this suture lasso. And once you have parked it over the posteromedial cannula, the next step is preparation of your femoral tunnel. And your femoral tunnel should be 8 to 9 millimeter away from the subconval bone and try to recreate it in the anterosuperior quadrant. For ACL, we try to be low. For PCL, we try to be high over the femoral attachment. And again, with this femoral J, try to make the femoral pose. So once you have make your femoral J, you will see it will come to the center of your rounded J. And now protect your ACL with your protector, and so that you are making your femoral tunnel from the medial surface of the femoral condyle and do it under direct vision. So now you can see here my curator acting like a protector, and now the suture lasso which we have part in the posteromedial compartment, you take it through the femoral tunnel. And over this, you can see here, and now I am parking it inside the femoral tunnel. Now my graft will go from the tibia, it will come up to the killer angle, and then it will go towards the femoral tunnel. The most important part is passing of the switching rod, because you can see your graft has to move at 90 degrees to pull it directly. So the best thing is that you try to push it with the switching rod posteriorly, so your graft goes posteriorly and then come up. So it's easy passage for the easy passage of the graft. And you can see here gradually the graft is coming towards the femoral tunnel. You are pulling it, your assistant is pulling it, and try to put your guide wire at this stage only. This is the best time you can put your guide wire, try to make it over the anterosuperior quadrant. You can see here, now I have passed my guide wire and hold it with your artery forceps, and then your assistant will gradually pull the graft inside. Be very careful here because you have been through and through the femoral condyle. Sometimes if you with inadequate pull, sometimes it's very difficult to push the graft towards the femoral tunnel. So gradually you can see here, my graft is now, I'm pulling my graft towards the femoral tunnel. Normal 5 to 20 millimeter of graft in the femoral tunnel. The standard rule is it should not be less than 15 millimeter, and at least 20 millimeter of graft should be inside the femoral tunnel. And gradually you can see the mark is there. So once your vital mark is reached there, you are sure that yes, my 20 millimeter graft is inside the femoral tunnel. You can fix it with aperture fixation. And always try to see the tip of this screw. Now so you can see my scope is focused over the big guide wire, and try to see the tip of this screw. Sometimes you can't because of the soft tissue pushing coming out with the graft. You can't see the tip. You can probe it with your probe. You can see yes, one thread has come inside the right, and at the right time you can see yes, the whole of the graft has good aperture fixation over the femoral tunnel. And you can see here with this probe you can palpate the tip of the bio screw or a metallic screw. And now with in 90 degree of the knee flexion, if you give an anterior rod, you can see the residual laxity in the ACL is obliterated. It suggests here because of the posterior insertion sexual was there, that has been obliterated. And you can see here, now you have to fix the tibial tunnel with aperture fixation in 90 degree of the flexion and anterior rod. And this is very important. Your assistant should give a good anterior rod, you can see here, so that there is no residual laxity inside the knee. And in 90 degree flexion of the knee, you fix your tibial tunnel. And you can see visualization of the graft to the posteromedial footer. It's almost 15 to 18 millimeter below the joint line, and that is important to see the good posterior tibial support. Thank you.
Thank you, sir. For the next topic, we know the success rate of ACL reconstruction is approximately 75 to 97%, with the incidence of failure increasing The incidence of revision ACL is also increasing day by day. It requires years of experience for proper planning and execution of the plan for revision ACL reconstruction. I'd like to request Dr. Arvind Gupta sir from Paras Hospital for his talk, revision ACL reconstruction planning and technique.
So, as incidence of ACL reconstruction surgery is increasing, the failure rate is also getting increased. So, this patient came to my OPD 6 months after ACL reconstruction, which was done outside, with he can do pivoting and ATS subluxation of tibial right himself. So, of course, this is a case of ACL reconstruction which is failed. Incidence is almost 1% to 30%. After ACL reconstruction. So what constitutes the failure of ACL reconstruction? That is recurrent tear, stiffness and arthrofibrosis, pain and arthritis after ACL reconstruction, persistent instability like this, and extensor mechanism dysfunction. All these conditions leads to failure of reconstruction of ACL. And why reconstructed ACL get failed? The first is the trauma. Like this case, 1.5 years of ACL reconstruction, and because of fresh trauma, this get failed. You can see the inclination of the graft is fine, tibial attachment is fine. The next is the technique, and the most common malpositioning of the tunnel is in femur, which is the vertical placement. And that leads to rotational instability in the knee and long-term disc ligament get failed. Again, there is either two anterior placement in the femur or two posterior placement in the femur. That again leads to failure of this. And also the malpositioning of tunnel in the tibia. If it is placed too anterior, that leads to the impingement over the roof. And if it's placed too posterior, that leads to impingement of the PCL. So all these malpositioning of tunnel will lead to failure. The next is the biology, whether your reconstructed ligament is healing with the bone or not. So in this case, 6 months after ACL reconstruction, still instability was there, and you can see the reconstructed ligament was not healed with the femoral part. The next is the associated wrist injury, like grade 3 pivot test, usually having lost anterolateral complex structure and other secondary stabilizer of the knee. Many a time there is associated present factor, like female athletes is having very high incidence of failed ACL reconstruction, particularly if associated with generalized ligamentous laxity. And the malalignment, that is very important. Like this 42-year male guy having ACL tear with the varus on the medial side, which was confirmed with the long leg film. So this case was operated with high tibial osteotomy along with ACL reconstruction. Isolated ACL reconstruction will lead to graft failure in long time. So evaluation of such type of patients should start with the history. In which time this get failed. If less than 6 months, then it means this may be because of biological failure or technical failure. If it is more than 12 months, then this failure is because of trauma. Many a time aggressive rehabilitation will lead to early failure of the ACL. And in physical examination, each and every aspect of knee should be examined very carefully, so that any missed injury at the time of reconstruction of ACL should be identified and should be taken care in revision. X-ray should be a start with bilateral knee with AP and lateral view, and also the long leg film to look for any varus deformity or valgus deformity in reconstructed knee. CT is very important to look for the diameter of the tunnel of the ACL, which was done in the femur and tibia. And this diameter, anything more than 16 millimeter, then a stage surgery. This should be done in 2 stages. And this axial view in the femur, tibia, and also over the CT scan, we can draw the future ACL tunnel in both in the femur and the tibia, and look for whether it's colliding with the failed tunnel or not. In the MRI, we can see the status of the graft, meniscus condition, and the cartilage condition. Because in almost 60% of the failed ACL reconstruction, there will be lesion in the cartilage and the meniscus. Like this case, 38-year male, 5 years after ACL reconstruction, though instability little bit was present from very early time. You can see the tunnel position in the femur. The literature was published in 2011 in American Journal of Sports Medicine, how to calculate the inclination of this tunnel. So anything less than 33 degrees will be taken as the man positioning in the coronal section, and anything inclination more than 55 degrees will be taken as again man position vertical graph. So this was the man position graph, so it's fairly long term. The long leg film was taken to look for any malalignment, varus valgus, and the MRI says there is a medial meniscus loss and the graft was ruptured. MRI in the coronal plane. So this was the examination under anesthesia. You can see the grade 3 anterior drawer, and also there was a private cyst was positive in this case also. So there is anterolateral structure was also compromised. This was the intra-op picture, the ACL graft, and this was the condition of the medial meniscus. So contralateral semi-T quadruple was used along with the fiber tape. Diameter was 10. Diameter is key in revision ACL reconstruction. And since grade 3 private cyst test was positive, so anterolateral complex was also reconstructed in this case using contralateral graceless. And this was in the post-op period. You can see now graft tunnel is more anatomical, both in the femur as well as in the tibia. So nearly tunnel both for the femur and the tibia was created. And this is after recent 1 month earlier. This is the clinical test. So from grade 3 anterior dot, there is no anterior dot at all. And this is almost 1.5 year follow-up of this patient. So he is doing fine. So what are the points should be considered at the time of revision of ACL? Whether it should be done in single stage or 2 stage because of tunnel, which graft should be selected, hardware removal, bone tunnel replacement, graft fixation and rehabilitation. But the staging, hardly less than 10% of the cases need 2 stage, particularly in which the tunnel diameter is more than 16 millimeter, either in the tibia or femur. So in this case, this tunnel should be grafted, and once it got healed, then the revision ACL should be done. For those who have loss of motion or malalignment. About the graft, there is a lot of graft available in the same limb or contralateral limb can be chosen according to preference of the surgeon. But the diameter is the key. It should be 9 or more than 9 millimeter. So hardware removal should be done only when it's in the line of the anatomical tunnel. Otherwise, it can be left as it is. Like this case, this was the failed ACL reconstruction with tibial tunnel was fine. And after removal of the screw, this tunnel will look like this. So there is debris of the graft and the screws is there. So this should be reamed further so that the raw cancellous area should be exposed for the graft. And newly tunnel was reconstructed in the femur and fixation was done with the screw and the suture disc, double fixation on the tibia. So if you are using the same tunnel in the femur, so any graft remnant or screw remnant should be removed. So this is the case came to me in 2015 August with 2-time ACL reconstruction with posterolateral corner reconstruction and osteotomy for the tibia, having instability in the knee. So his study started in 2013 and he has bicondylar tibia fracture, which was fixed with the bicondylar threading, but his instability continued for 1 year. Then after 15 months, removal of both the plate and the reconstruction of ACL with bone patellar tendon was done. And after 2 months of that, the osteotomy for the anterolateral proximal tibia was done. But his instability continued, and almost after 8 months of that, the revision of the ACL was done. This time there is broken guide wire in the femoral tunnel, and at the same time, posterolateral corner reconstruction was done. But you can see the posterolateral corner reconstruction, the femoral isometry was too anterior, and also tunnel for the ACL was too vertical. So again, this both the structure get failed, and patient came to me after almost 2 years of all these reconstruction part, moved all over the India because there was no graft. He was used a bilateral hamstring and the bone patellar tendon on the same side. So this in the 15, and we took the case for reconstruction, revision of the ACL and the posterolateral corner reconstruction. So evaluated with the CT, you can see the two screw in the femoral tunnel, and the femoral post is too anterior there. The CT, the coronal section, axial section, single hole in the tibia, which was almost 12 millimeter there. So the first time the peroneus longus in 2015 was used bilateral by me. I used first time this peroneus longus. The bilateral peroneus longus was used, one for the ACL, another for the posterolateral corner, and this gives almost diameter of 10 millimeter. And fiber tape was used for the ACL, and this was, now it's more anatomical. This was the original tunnel, and this is the revised ACL with the suture post on the tibia along with a screw in the tunnel. 12 millimeter screw was asked for the tunnel, and the posterolateral corner was revised. From there, the screw now post is on anatomical side, and this is for over the tibial side. So posterolateral corner was reconstructed. This is almost after 1 year when this patient came to Patna for marriage, and this is came again after 6 months, but there was a screw problem, so a screw was removed. So now in between, almost for last 4 years, he was not in contact. Today morning, I called him because his number was with me, and this video is from 8 a.m. today morning from the Bangalore. He is doing all the activity after this third ACL reconstruction and posterolateral corner. About the rehabilitation, it should be slow. It should not be aggressive, and this usually takes time, even a year, to get back to his work. Thank you.
Thank you, sir. Multi-ligament knee injury is associated with both limb and life-threatening complications. Proper management starts itself from the emergency room. I'd like to request Gurudev sir from Universal Hospital for his talk on multi-ligament knee injury.
Good morning, everybody. Respected chairperson and dear delegates. I'm here with my topic, my approach to multi-ligament knee injury. The spectrum of injury, it varies. It may be ultra-low knee injury dislocation in the obese patient following simple mechanical fall, low energy knee dislocation while playing sports in the field, and high energy at the time of road traffic accident. The principle of management expectation and the outcome differs from individual to individual. This shows the same classification of the knee dislocation. The goal of treatment is a stable and painless knee with full range of movement and returns to pre-injury level of activity. The emergency management is to X-ray, exclude the fracture and malalignment of the knee, reduce the devastated dislocation in the emergency room as early as possible by direction, and reassess the neurovascular status pre and post reduction of the dislocation. If there is any vascular injury, go for CT angiography, aspirate the knee if necessary, and split the knee with the plaster of Paris. The external fixation and the emergency operation needed when the reduction is not achieved with the plaster of Paris, vascular injury, open injury, associated fracture, KD type 5, compartment syndrome, and irreducible dislocation. The diagnosis of multi-ligament knee injury is really confusing. Sometimes it looks like 3 or 4 as shown here. The MRI gives the clear picture of the meniscus, articular cartilage, ligament, and tendon. On left side there is ACL, PCL, and MCL injury, and on the right side there is ACL, PCL, and PLC injury. Sometimes a stress radiography needed to know the status of the collateral. By putting the varus force, there is opening of the lateral joint line that indicates there is PLC injury, and valgus force, there is opening of the medial joint line grossly that indicates there is MCL injury. This is the clinical examination of the knee ligament injury, the ACL, anterior drawer test, pivot shift test, PCL, posterior sag sign and posterior drawer test, MCL, valgus stress test, PLC, varus stress test, ACL and PCL. The dive test, then increased external rotation at 30 degree, there is PLC injury, and increased external rotation at 30 and 90 degree, there is PLC and PCL injury. So the management is the operative conservative. The timing of surgery early or delayed, repair or reattachment, versus reconstruction or simultaneous reconstruction of the cruciate, or it will be later on as a stage procedure. The timing of surgery, there is still debate whether to operate and when, but it should be operated between 10 to 3 weeks of the injury. This is a 20-year-old male following a road traffic accident, examination under anesthesia, a stress radiography and clinical examination, and the MRI, there is ACL, PCL, and MCL injury. So we plan to reconstruct all the 3 ligaments in the same sitting, prepare both the leg, harvest perennial longus graft from the ipsilateral leg, and the hamstring from the contralateral leg. Then patient lying supine in the operating table with under the pneumatic tourniquet. Put the scope inside the knee joint, divide all the remnant fiber of the ACL and PCL, and pass the guide wire to create the PCL tunnel. It should be below 1.5 centimeter from the joint line. Sometimes we use the help of the CR. This is the intraoperative picture during the procedure. For MCL reconstruction, pass the 2 guide wire, one over the middle femoral condyle and another on the tibia on the exact attachment side of the MCL. Tie one ethibond both end of the guide wire and check the isometry of the MCL. If it's okay, then drill over the guide wire according to the size of the graft and fix it in the 30 degree of flexion and with varus force. We do anatomical laparate for PLC reconstruction, make a hockey stick incision on the lateral aspect of the knee, make isolate the common peroneal nerve, then pass the guide wire over the fibula from anterolateral to posteromedial direction, then drill over the guide wire according to the size of the graft, pass the loop wire through the fibular tunnel, then pass the guide wire on the anterolateral aspect of the tibia for the tibial tunnel creation. Then drill it according to the size of the graft, then pass the loop wire. Now make a 4 centimeter incision over the iliotibial band, locate the exact attachment of the FCL and the popliteus tendon, pass the guide wire, drill according to the size of the graft, pass the graft through this tunnel and fix it with a screw. Now harvest the FCL underneath the IT band and soft tissue and retrieve the graft through the fibular tunnel. And lastly, retrieve the popliteus underneath the soft tissue and simultaneously retrieve the graft through the tibial tunnel, put the guide wire, do cyclic loading and fix over the tibia. So we follow the normal standard protocol while fixing the graft, including the multi-ligament reconstruction. And this is the 20-year-old professional cricket player. He had multi-ligament injury 2 years back. He had ACL, PCL, and MCL injury. Today morning, I got this video, and he got selected a couple back in Indian Bihar Cricket League match as a costliest player. So take home message: diagnosis of multi-ligament injury with high level of suspicion, radiology, and clinical correlation must. Revise steps, your plan, read literature before surgery. Don't be panic intraoperative. Don't leave anything unaddressed will cause poor outcome and failure of the graft. Make a logical sequence of fixation. Stiffness is a major concern. Thank you for your patience. I am going to organize a Patna knee course, arthroscopy and sports injury meet under the aegis of Bihar Orthopedic Association on 10th April 2021. I request all
Shoulder enjoys greatest degree of freedom in terms of range of motion at the cost of its stability. It is the most frequently dislocated joint in our body. I'd like to request Dr. Ratnesh sir for his talk, approach to recurrent dislocation of shoulder.
Good morning. My talk is based on anterior dislocation of shoulder. More than 95% of the recurrent shoulder dislocation is anterior. So my talk is confined on recurrent anterior dislocation of shoulder. First, we need to understand the two main pathoanatomy of this anterior dislocation. First is band-flat lesion, and the second is bipolar bone loss. Due to the recurrent dislocations, both humeral head gets heel sac lesion due to impingement, like impingement fracture, and due to repeated dislocations, anterior glenoid bone loss is also present. And investigations. We need both MRI and CT scan with reconstruction. In the MRI, you can confirm your diagnosis. Typically, the capsule and labrum detached from anterior glenoid. You can see the black line, which showing the detachment, and the white line showing the attached posterior labrum and capsule. Need CT scan with 3D reconstruction. In the CT scan, you can find bony vanguard lesion. Sometimes the lesion is too big. In that case, you need open detection dermal fixation. You can also quantify the heel sac lesion in the CT scan cuts. Now the surgical options. More than 150 surgeries and modifications have been devised to treat traumatic recurrent anterior instability of shoulder. But for all practical purpose, the most commonly performed surgery is arthroscopic stabilization and letargy procedure. Which procedure to choose in which patient, that's very important. So the choice of surgery, whatever you choose, will depend upon glenoid bone loss and heel sac lesion, whether it is on-track lesion or off-track lesion. Now first, we should assess the glenoid bone loss. In that, we need digitally subtracted humeral head, and we need to see the oblique and end-face view of glenoid to look for the bony loss. Glenoid is pear-shaped and lower part makes almost circular. So make a circle in the lower part of it and assess the bone loss. Now, whether the lesion is on track or off track, to understand this, we need to understand glenoid tract and heel sac interval. So, what is that? Glenoid tract refers to the area of contact between the humeral head and the glenoid, and it is defined as 83% of the glenoid width. In the first picture, you can see the pictorial representation of glenoid tract and its effect. In the picture B, you can see there is the anterior bone loss and there is significant decrease in glenoid tract. Second thing is hill sac interval. It is the width of hill sac lesion plus the width of bony bridge between the rotator cuff attachment and the lateral aspect of hill sac lesion. Now, whether the lesion is on track or off track. So when hill sac interval is smaller than the glenoid tract, the lesion is on track. What is the significance of it? That the head will maintain contact and is at lower risk of engagement and instability. Repeated engagement of the lesion can lead to failure of your arthroscopic construct. Off-track lesion, when the hill sac interval is larger than glenoid tract, then the lesion is said to be off-track lesion. Off-track lesion can result from either a large bony bifid lesion or hill sac defect, or from a combination of moderate size hill sac defect and moderate size bony bifid lesion. What is the significance of it? It will be at increased risk of repeated engagement and instability, and it will lead to the failure of bifid repair. Now, on the basis of these 2 points, we can group the patients into the 4 groups. First group is less than 20% glenoid defect and glenoid bone loss, and if the lesion is on track, we can safely do the arthroscopic bifid repair. If the lesion is less than 20%, but the lesion is off track, then we need to add remplissage to protect our arthroscopic bifid repair. If the glenoid defect is more than 20%, then arthroscopic procedures are not very effective. It is better to go for the letarge procedure. And if glenoid defect is more than 20% and the lesion is off track, then after doing the letarge, we have to check whether the lesion is engaging or not. If it is engaging, then we have to add some procedures with the letarge, like remplissage or mid bone grafting. The target has been covered by the previous speaker, so I am concentrating more on the arthroscopic bifid repair. It is most commonly performed surgery, excellent results, very short of hospital stay, but the problem is a long learning curve. So, first to put the remplissage anchor if required. Remplissage means filling the defect. We are filling the defect with intraspinous tendon and making the intra-articular lesion into extra-articular. So first to put the remplissage anchor, because once you repair the bifid lesion, you won't be able to put this anchor, and pass your sutures through intraspinous tendon and leave it as such. Don't tie the knot. Then do the bifid repair. The 4 stages you need to do properly. All 4 are important. First, to release the capsulolabral complex from anterior glenoid. This is the most important stage. You should release this properly, because if it is not released, your repair may compromise. Repeat, release till you see the fibers of subscapularis through the defect. Then you divide the loose stacks and fibrous tissue. Prepare the bone properly, either by a rasp or the burr, and then complete the repair with suture anchors. Most of the time you need 3, sometimes you need 4, depending upon the size of the repair. Then you tie the remplissage anchor suture. Once you tie, you can see in the picture A, the whole defect has been filled by intraspinous tendon, and picture B is the diagrammatic representation of the whole repair. Where anteriorly you can see the anchors fixing the bifid repair, and posteriorly you can see the remplissage anchor which is fixing the tendon with the defect, and the repair is really done. Thank you.
Thank you, sir. This ends the talk. Any questions from the house? Yes. Thank you, sir.
Thank you, sir, for considering this session. So, our next session is on adult lower limb trauma. I'd like to request Dr. Ravindra Narayan Singh sir and Satyanuram Ram sir to please come and chair the session. Ravindra Narayan Singh sir and Satyanuram Ram sir. Sir. Probably Ravindra Narayan sir is not there. May I request Dr. S.S. Jha sir to please come and share the session. Thank you, sir. So there is some reshuffling in the presentation order. So may I request Dr. Amit Asgaonkar sir to come and present in this topic, that is distal femoral plating versus nail. Dr. Amit Asgaonkar sir. Okay. So I would like to invite Dr. V. Shivshankar sir. Yeah, yes. Dr. V. Shivshankar sir to please come and present his case. So his first topic is reduction technique in subtrochanteric fracture.
Good morning, friends. Before really V. Shivshankar starts talking, let me have the privilege another Shivshankar to call upon the President IOA for giving his illustrious talk on reduction technique in subtrochanteric fractures. Dr. Shivshankar, please.
Thank you very much, Professor Dr. Shivshankar Jha. I would like to thank Amulya for again inviting me for this beautiful get together after a prolonged lockdown. Friends, that's my theme, Atmanirbhar Orthopedics. But coming to my talk, the commonest problem in a subtrochanteric fracture is the varus happening, especially in high subtrochanteric fracture, because the wide proximal medullary canal where the nail can enter to the medial part if you take the red line as the entry. So you have to avoid this problem by keeping the nail parallel to the lateral cortex. That's the crux of the treatment. So instead of going medially, the wire, which is the red line, you have to keep it, the green line, parallel to the lateral cortex in AP and parallel to the anterior cortex in the lateral lobe. This is the crux of the whole treatment in this fracture to avoid the problem. Coming to the entry, there are various entry, tip just lateral to the tip, piriformis fossa, piriformis fossa is slightly posterior. What I advocate is it's in the center, medial to the tip. Basically, it's a piriformis fossa entry itself, but it is in the center of the neck in the lateral picture. That's what we should aim. Don't think about the small bend given to the proximal part. See, if you take the tip of the trochanteric entry, it is beautifully reduced. It's still beautifully reduced. What happens when the nail goes inside? The proximal fragment goes into varus. So this is the reason why you should take the entry much more medial to avoid this problem. So this is the end result, which was very good initially. Unfortunately, the nail has displaced this fracture. Getting a hold on the proximal fragment is very, very important. You have to adapt and interrotate it. A recently done case, this is this lady. To prevent the intertrochanteric bursting open, I have fixed the fracture with 2 KYs. Then I am taking an entry. You can see the Steinman pin is pulling down the fragment and adduction and interrotation. Then I am taking out a 10 mm chunk of bone to make a canal. Just because there is a fracture, don't push the nail inside. So then I am keeping it parallel to the lateral cortex in all the steps. Then only my nail will remain in that part, and that will avoid the varus. So this is a very elderly lady I had treated very recently, just after the lockdown, sometime in October, I think. This is the immediate post-operative picture in September. This is at 5 weeks follow-up, you can see already the patient is walking beautifully and there's no problem. Unfortunately, I couldn't get any more problem, as you can see in my conversation with the place where I operated. The patient had not come for follow-up. This YouTube video, you can see a demonstration case I had done in Akola in Maharashtra. This is very, very useful. Many of the tips have been discussed. Coming to little difficult cases like intertrochanteric with subtrochanteric fracture, you have to reduce the intertrochanteric element first, fix with a screw or K-wires. As you can see, I have fixed this with a screw first, then I'm converting this into a pure subtrochanteric fracture, and I'm adapting, interrogating with the help of the Speedman pin, and I'm making a fresh entry from the piriformis fossa, the central lateral view, and I have done the nailing and have got a very good outcome in this patient. So this is very, very important. If there is a fragment medially in the weight bearing axis, it's always better to open, reduce, and fix with wires, because this is the place where weight bearing happens and you cannot take a chance with the close reduction with a mal-reduced fragment. So this I have demonstrated in cases also. But if there is a long oblique fractures, if the obliquity is more than 1.5 inch, then I don't mind putting a percutaneous surplus wire like this and get the reduction well. With a small incision with our Indian instrument only we can get it. So this is a imported one which costs about 5 lakh rupees, but an Indian Atmanirbhar one costs about 7,000 to 10,000 rupees in our market. This is an intertrochanteric fracture with a subtrochanteric extension. These are some displaced picture. I don't have all the pictures, but I fixed the fracture with K-wire first. Then I inserted a Speedman pin to adapt the fracture. Then I have taken an entry and passed the nail. The subtrochanteric element, what I have done is I have passed a encirclage wire, percutaneous encirclage wire. So this is very, very useful. So normally we have to expose the linea aspera because muscle is attached there. Then you have to insert the inferior tongue of the encirclage wire passer first. Then you apply the superior one. Once you clamp them, then it's just a passing wire from one end, it comes out from the other end, and you can just tighten over that, and don't tighten it fully before you pass the nail. After passing the nail, you have to tighten this, and this is the clinical picture on table, and this is the immediate post over X-ray. For such a bad fracture, it's a very reasonable reduction. I could get with a small incision. For use for the neck screws only, I have done the encirclage wire. Another elderly lady of 92 years, and you can see again intertrochanteric with subtrochanteric fracture. Again fixed with K-wires first, made an entry. My guide wire is going parallel to the lateral cortex. Then I have passed the encirclage wire because the proximal fragment was getting abducted. Then how I do a cable. See, cable is very costly, 5,000 to 6,000 rupees. But I usually use 50 rupees, 2 wires, Drummond wires. I ask the assistant to hold with the T-handle check on one end, and other end I pick the drill machine, I rotate it, it becomes a cable, just 100 rupees. The reason that cable, advantage of the cable is, if you use a simple thick wire, it will be touching a lot of area of the periosteum and blood supply will be curtailed to the fragment. If you use, as you can see on the right side, if you use a cable, little area only will press the bone. This in the neck there was a varus reduction, and what I did was I used the encirclage wire, I reduced the fracture, and this is the immediate post-operative picture. Is 92-year-old lady. There is no place for replacement as far as I am concerned, even in such bad fracture. Another case, again similarly, I am treated with the encirclage wire and made an entry properly, and you can see that the beautiful reduction could be got. Unfortunately, I couldn't search and get the details. This is the last case I am showing. High subtrochanteric fracture with a large butterfly fragment. Again, what I have done is passing the wire to get the alignment first, then pass the Speedman pin and hold it on the proximal fragment, making an entry, enlarging the entry, then I'm passing a finger to get the reduction. This is the finger I use for reduction. Once the guide wire is in the distal fragment, I have reamed it and passed the nail, and this is the final AP of the neck. I always want the beak to be out. Beak should not go inside. In the lateral also. And additionally, I have added few more encirclage wire and this is the final picture on table. A beautiful reduction for such a bad fracture. Distally, there was a bad wound in the thigh, so I didn't do the dynamic distal locking, but this is the 1 month post-operative and this is the 5 month post-operative. You can see that the fracture has consolidated. So don't accept mass reduction. You can do mini open reduction and put a screw or wire. There are percutaneous passing instruments which are available in the market. You should know all the techniques. You should know all the technique to do this surgery. So this is about my subtrochanteric fracture. Before next talk, I will finish the next talk also. Yeah, because Amit is talking on distal femoral fractures. So probably I share a lot of pictures. We share a lot of pictures together. So let me finish the talk since I am here. So coming to the next talk, if the distal femoral fracture, nailing is resurging back. Friends, we have treated in the past by various plates and nails, but once the locking plate became available, we started doing the surgery. Definitely, I feel that nailing is a better option, especially if there is a bad combination or loss of fragment. Locking plate problems, we are nowadays seeing a lot of them. For distal femoral plate, we have to fix with 2 plates to get good results. This is a very devastating surgery. You will definitely get, this is again Dr. slide from Dr. Amit Ajitokar. You can see a badly communicated fracture. He has used 2 plates and he has got an excellent result. Yes, so much of exposure is required for distal femoral fractures. What I am talking today is plate is not a good implant because it is absolute stability. Amount of callus found is very, very less. This article by Henderson in 2009, they say that at 3 months with a plate there was hardly any callus seen, whereas with a nail there is subtle instability, lot of callus is seen. That is 330 millimeter cube, 0 versus 330 millimeter cube. So this is only because nail can allow little axial micromotion like a Ellis rope, which is absolutely not there with a plate. So that is the reason why we are now having a far locking cortex, because we want to have some micromotion near the plate with the screw. That is the reason why these costly implants have arrived in the market, which are far locking cortex one which is available, but it is too costly for all of us to use. I have not used one. This is a borrowed picture from the net. Coming to the nailing, the problem with the nailing is centralizing the distal fragment is very difficult. You have to use polar screws, or better will be to use a multi-locking screws. Then you will get beautiful callus all around. So luckily, we have got a multi-locking nail available. This bolts gets locked within the nail. This is a beautiful implant which is available in the market. It costs hardly 5,000 rupees. And earlier I was using a simple nail like this, but now I shifted over to the multi-locking. So this fracture I have treated both with keyhole incisions. Another fracture, another few cases similar. A polio patient, again I have used a nail, and I have, this is a medical student, he could put an external segmental fractures, again treated with a nail. Intra-articular combination, I just fixed with few wires, and this is the end result in the same patient. Elderly patient with a split, again intra-articular split. I reduced the fracture and put in a nail inside. This is at 6 week post-operative, and this after the fracture is consolidated, just before the implants are removed. Let me show some bad cases. It's easy to treat an extra-articular fracture. Let me show badly communicated fractures, how good this nail works. You can see that I have played jigsaw puzzle to put all the fragments around the nail. This is one of the immediate post-operative X-ray, and you can see after 13 months, patient had a good consolidation around the nail. Another fracture. See, there is hardly any medial bone. If I had done plating, it should have been 2 plating. But this patient also had a fracture patella. See the gap medially, friends. See the gap medially. The plate will never accept a gap there. But with the nail, you can see that beautifully the fracture is consolidated. This is after the implants have been removed. So patient had an excellent result. If I treated this patient with a plate, definitely just with lateral plate, this is a plate. See the communicated fracture, again C3 type of fracture. Again, I put a nail and fragments around the nail with the help of some screws. And this is the 4 months, you can see about 90 degrees. At then he had about 110 degrees of flexion in the knee. I have already removed the implant in that patient also at 120 degree. This a multi-locking nail I have used. This was a young patient, so I used a nail augmentation also. These are some of the intraoperative steps to show how I have passed the nail. Then I have added a augmentation plate percutaneously on the lateral aspect because there was a large butterfly fragment. Always keep the knee at 90 degree. Getting extension is not a problem. Getting flexion is a problem. All my knee, whichever I operate, I always put them on a 90 degree frame like this. This is the nail with augmentation. This is at 4 months. Patient had a good function. At 7 months, you can see that the patient is walking. This is on the right side. I have treated this patient with a nail with a locking plate. So he is able to squat and get up unsupported. This another patient, elderly patient, I have done a multi-locking supracondylar. This video is available on the YouTube. You can see the whole video. This patient never came for follow-up. I sent one of my assistant doctor to his home, and he said that you can read that the patient is not ready to get an X-ray done. This is the clinical picture at around 6 months after the surgery, but the patient refused to come to get an X-ray done because he's so happy with the function. This was a demonstration case done. I think Amit was there with me at that time. There was a prosthesis proximally. I have done a nailing, multi-lock nailing. This is a very good indication with the prosthesis above. This is Amit's case itself, intertrochanteric with badly communicated supracondylar fracture with a shaft fracture. You can see he has beautifully used these implants, and this is one of the best cases I have seen. Such an excellent result he has shown. This at 6 months, the patient had a full function. You can see active extension is possible. If you take care of the entry point properly, then no problem. The patient will never have any problem. This is the last case I am probably showing. A ununited fracture in the distal femur. Again, I have used a supracondylar nail with an augmentation plate with the polar blocking screws. 1, 2 are the lateral-medial blocking screw, and 3, 4 are anterior-posterior blocking screws to jail the nail. And this is just at 4 weeks. The patient who had not walked for about 1.5 years started walking at 4 weeks. This is the beauty of this surgery if you do it well. This is the nice consolidation at 9 months time. Again, this patient is also walking and is able to squat and is able to get up unsupported. I am telling unsupported, he is able to get up and walk. A malunited fracture, again I have used a supracondylar nail to correct as a osteotomy fixing implant, and this after the implants have been removed. This is my friend Dr. Milind Chaudhary has used for a shortening with a valgus deformity. He has used beautifully with polar bolts the supracondylar nail, and he has done the lengthening with a extra fixator outside, and he has got the alignment beautifully back. Friends, definitely nailing is coming back. We should know how to avoid complications. You will get beautiful results. Plating is not the only answer. You should know both the things, but definitely nailing is, I feel nailing is far better than plating. Thank you very much. I thank all of you for allowing me to finish both the talks because myself and Amit are going together for 1 o'clock flight.
Excellent presentations, and you have definitely shown that platers should not forget nailing and nailers should not forget plating. There are definite indications for doing well. Now we switch over to the next presentation. Amit Hazgaonkar is already here to make his presentation.
So the topic of the presentation of Dr. Amit is distal femoral plating versus nailing. So it's a continuation of
plating versus nailing, but then though I do mostly platings as Shiva also does, because we are a part of the nails con and we really believe in nailings. Dr. Johnson will not probably. But anyway, both are good. It's not that nailing is only good. The main aims of our fixation should be the alignment, the length. Articular congruity is very important. Maintain a normal mechanical axis. Now look at this. This is a simple extra-articular fracture. You may go and reduce it. If you want, you can put interfragmentary screws, but then the way you have to plate it. First, this screw, which should be parallel to the joint line, do not tighten it. Then put your upper screw. Otherwise, you will have a helicoptering. This is most important in nailings and in platings, and your plate should be long enough. Today, short plates are not used. All long plates till you are lesser trochanter. All long plates with a few screws up and a few screws down. And this is the way you do it, and you get this. The length of the plate should be at least 3 times more than the working length of the fracture. Now this slide I think Shiva has shown, but one thing in here I would like to say that plates also give you callus, but the callus is only on the opposite side, that's the medial side. Whereas the nailing throws circumferential callus and there is micro motion. Unless and until nailing gives you macro motion. Macro motion would be seen in porous fractures, wherein you put those polar screws and prevent macro motion. This is a case which I did in the COVID, but this I just did reluctantly because there was no nail. The nailing person comes from Ahmedabad to me, and he's the only person whose nails I used. I showed you how beautiful nails he has, and unfortunately in COVID he could not travel. But then here, this small fracture over here, I was not sure that it would unite, and this is around 3 months, and this is 6 months follow-up, and later on the patient went to unite. In platings, if there is medial combination, if the plate is less than 10 holes or a short plate, and all locking screws put, or there's a distraction at the fracture site, sure short predictors of failures. You see more failures because it is not the implant, it is the way we do it. Both the nail as well as the plate. You need to have absolute stability at both the ends, and in the shaft you need to have a no-touch technique, and axis and length should be maintained. Now look at this. This is a C1 type of fracture. We went ahead and did this nail. This nail is slightly different than the one which is very openly and widely available in the market. But this nail is having locking bolts on both the sides. So the C1 type of fracture can be slightly compressed. You don't compress it more, slightly from both the sides. And it's a long nail. It goes up to the lesser trochanter, and at the lesser trochanter it has got an AP locking. Now, at the level of the lesser trochanter, if you put a lateromedial locking, it's very difficult to get a lateromedial locking at that level. And here, this was 14 months back, the patient had united, no patellofemoral problems. This is another C1 type of fracture where we went ahead with this small incision, just a small incision. We did this nailing, and this was done in a government setup, and the second day the patient was fine, sitting and with all range of movements. The crux of the matter over here is the second day range of movements. Shiva has already told you that range of movements with a CPM machine has to be started. You have to put the patient on a CPM. If you have your own hospitals, you should have a CPM machine, and immediately you put them on that. This is another C1 type of fracture wherein we have done this nailing, lot of combination. In such a combination, what would you have done with a plating? Just a lateral plate or a medial plate also? So you have to think, that's a controversy nowadays. But then with a nailing, it's a distal load-bearing implant. It's very simple to get away with. And this is the particular nail with multiple multi-directional lockings. And this particular screw, these are bolt screws which have got good hold at the near cortex with the pitch increased. In another case wherein we went ahead and we hold it with a patella holding forceps. Then you may put K wires just to hold a fracture. After that, you pass a nail. And the first screws, if you want to either tighten it, in the C1 type of fracture, you have to compress it. Then you have to first do those. These are called as bolt screws, and from both the sides, they are tightened first. And then the nail is put. This is the anterior-posterior locking at the lesser trochanter level. Go do this, and then this is the last incision, 2 months follow-up, 6 months, and this is the year follow-up. This is another case wherein, look how bad the fracture is. You all will talk about the plate. I know it is a standard thing, but then we have got extended approaches, extended indications. Here, what I see is the bone stock. You should have a good bone stock in that distal fragment, and the patient should be relatively young with a good bone stock. If the patient is young with a good bone stock, then it's good enough. As it is, your plate is going to hold 3 or 4 screws. So why not a nail also hold the 3 or 4 screws, and you get a good straight alignment. So then the continuous passive motion exercises. CPM machine is a must. The second day I put all the patients on it stimulates a lot of articular cartilage healing and regeneration, the CPM, as well as range of motion. Now here it was said that in osteoporotic bones, as I've told you, there's a lot of tagging of the nail. The nail will not give you micro motion, it will give you macro motion. Instability in nailings is cured. This is the macro motion nails. So you block them. Shiva, I showed you this slide, and then put the screws distally, and then go ahead and do the nailings. I do nailings for also segmental type of fracture, the distal femoral nails, and they give a distal load bearing implant. It's an excellent implant. You need not depend on centralizing in the distal fragment. Your main intention in these cases should be that the nail should be centralized in the distal fragment in both AP and lateral, as well as it should extend up to the articular cartilage. Look how beautiful it is holding it. You can immediately mobilize these patients. This is another case where we went ahead and did the nailing. The patient's second day post-op was this, and this is a year post-op, all good results. You need not really worry about the combination because it's a nailing and you've got good results. This is another case. In these cases, if it's an osteoporotic, if you're just putting lateromedial lockings, just lateromedial lockings will have this motion. This is called as a bell clapper sign. The same thing as yesterday I asked in PFN. PFN, if you do for an ipsilateral fracture, neck and feel sharp, you have this particular movement. If it's only lateromedial locking. So you should have anterior-posterior as well as lateromedial lockings. Then all this movement is stopped. Or else add two polar screws there. We went ahead, we go ahead and do this for these type of fractures. This is another C1 type of fracture. We went ahead, we did this, another C1 type fracture. CPM started immediately. Patellofemoral joint is not at all disturbed. There are no joint problems, no knee problems. We all have thought retrospectively, just go and think what we used to think, because what is the evidence against the nail is that knee problems. But then now there is no knee problem at all. You have to keep your stability in the OT and maintain your movements. 4 screws distal locking in 4 directions is the way you have to put a nail distally. You cannot just go away with a distal femoral nail with just 2 lateromedial lockings. Never do that. You have to have 4 screws, 2 obliques, and 2 lateromedials. Go ahead and do this. More rate of non-union in plated patients than in nailing patients. This case, this is what I did it, and this case Shiva has already showed you. This is 18 months follow-up, and this is the video. Anyway, I'll go ahead because now in cases of nailings, even if you don't get a closed reduction, I do an open reduction. As it is for platings, you are going to open it and reduce it. You open it, reduce it, jigsaw puzzle, and drill a small hole in the center and put a nail. This is a very simple thing. And go ahead, because of the biomechanical advantages, the nailings are very good enough. And this is at 6 weeks. Take home is both are good enough. You should know your implant well. You should know the technique how to do it. For platings, you can do in all type of fractures, but for nailings, it is better in extra-articulars and C1 and C2 type of fractures. If you're a good nailer, you can go and do it in C3 as Shiva does it, as well as we do it. Clinical outcome is always largely dependent on the surgical technique. Never trust all what we say all the time. The faculty says all the time. It may be true in our hands at that time, not all the times, in all the hands. Thank you.
Thank you very much. So better biomechanical stability of this redefined retrograde nail has been well presented by you. Thank you.
Thank you so much. And thank you, Dr. Amulya, and everyone over here has been coming every year. And I really find a big difference in the crowd. They are all very interactive. And it's so nice to have this GOFCON every year. Thank you. We are leaving. Thanks a lot, Patna.
I'd like to invite question from the house because Dr. Amit and DC Shankar sir have to leave. So any question on these last 3 topics? Sir, Shankar sir?
John sir.
I think the conclusion of these 2 talks was if you did a plating badly, it wouldn't work. And if you did a nailing well, it would work.
It all depends on the way we do our surgical techniques. Thank you, sir. Thank
Sir,
you.
one question regarding the length of the nail, because standard teaching is that length should span beyond the LT or at least up to LT. But many times we found a smaller nail, particularly in government setup, we don't have that luxury of having all the inventory. So in Sankar's talk, I have seen that smaller nail that is only up till mid femur. So what is your recommendation, sir, for long?
Look, doctor, it's a good question about the length of the nail. Shiva, they are questioning your previous cases 15 years back, shorter nails. So today, nowadays, it is a nail till the lesser trochanter. These were 15 years back that he was showing. He has got good results, but then yet Today, if you're doing a nail, it should be the proper nail, it should be a long nail, and it's not a luxury. These nails cost you around 5,000 or 6,000 rupees. But the person is not there. You don't have that surgical company probably. We have it over there. He comes from Gujarat. But then that particular person, this particular nail, you should find it out and you should get it. It's not very costly at all. All the armamentarium is very cheap. Anyway, thank you.
Thank you. Thank you. I would like to request our next speaker, Dr. S. Samanta, sir. And his topic of presentation is SOPA's approach.
Dr. Swarnantu, please.
My regards to the chairperson and my seniors, Jhan sir, John sir is all there, and all my seniors and colleagues. I am going to present a small video, and probably I will finish within 8 minutes time, I promise. This is a small video on STOPA approach, because we all orthopedic surgeons during our, probably in the PG training and also in the residency, we are not exposed how to do the acetabular fractures from the front. Probably we see KL approaches. And this was the, if you see this sort of X-ray, this was a fracture dislocation of posterior fracture dislocation of the hip. So as we all know, and we do all the meetings in the acetabular meetings, and when we go ahead with the, whenever there is a posterior dislocation of the fracture, we all fix it from the backside. Okay. So it was primarily fixed from the backside, but there was still a big gap on the anterior column. So we had to go from the front. And when we started doing the anterior approaches, we all started doing the ilioinguinal approaches, because that was the approach we, at that time, probably our seniors who were teaching during the human specimen meetings. Then we started doing the STOPA. But nowadays, as because we are combining the STOPA along with the iliofemoral approach, nowadays, very, very rarely we are doing the ilioinguinal approach as such. So whenever you do the STOPA, it is just like a financial incision, is 2 centimeters above your symphysis pubis, and you have to just don't cut the rectus. When we started doing the STOPA, we usually start doing the cutting the rectus. Probably John will agree that we started doing the rectus cutting, but nowadays we just split open the linea alba. And the base trick of doing the STOPA, you once you open the linea alba, and once I will stop here just for the juniors, then when you split open the linea alba, please dissect the back side of your rectus, because that is the trick. Because if you dissect the back side just with your fingers, your bladder and every soft tissue and your peritoneum, all the problems in your mind will fall back. And put one wet sponge just at the space of radius at your symphysis pubis. Then another one trick I am for the telling the juniors that you have to release the rectus not from the top of your symphysis. It has to be released. If you see, the left side is the head side and the right side is the leg side. I am releasing all the rectus from the superior surface, from the front, and also I am probably going to the inferior most part of the symphysis. So that this is the first Roman that we are putting to take care of the rectus. And once you dissect the rectus from the front, then you go ahead and just follow your iliopectineal line. And from the symphysis, once you go ahead to the iliopectineal line, you will find the corona mortis. Okay. So that is the one important vessel that probably in 50% to 70% cases is being thrombosed. And if you find that it's a big one, you can either cauterize, you can ligate, or you can keep it. There are 3 things you can do it. If it's a small one, you can just barnish, or if it's a big one, you can ligate, or you can cauterize. Okay. So I will, another one trick for the juniors, never use the periosteum elevator. Always use the cob from your spine set, because the periosteum elevator, the ends and the sides are very, very sharp. You can injure something, because once you are leaving the pubic tubercle, you are very close to the femoral vein. And if you are very close to the femoral vein, then probably you can, it's a very, very thin structure, you can puncture it. Then you are probably is bleeding and your heartbeat will go fast. So remember another 4th point when you do the STOPA, tell one assistant that your hips should be flexed and externally rotated. If you do that, And usually when I do this stopper, one pillow is just below the knee. So the knee is always kept flexed and external. That is the way you take care of your blood vessels. Nothing dangerous. The second lever will just go lateral to your pubic tubercle. And once you go lateral to the pubic tubercle, then you take care of the femoral vessels. And just blindly follow the iliopectineal line. It is broken. That's why you are doing it. Okay. And if you follow the iliopectineal line, you will follow that. And up to that, you follow that anterior part of the SI joint. There's no danger. And the second lever is just lateral to the pubic tubercle. That is the way how you take care of your blood vessels. And third lever is just below the iliacus. So that 3 levers are there. And now you can see I am going to the SI joint. And the fourth one, you have to take care of the operator nerve. Okay. So once you release the operator internus, you will see the operator nerve. And the operator nerve is a very, very thick, wide structure. And the operator nerve will guide you one thing. If you follow the operator nerve to the top, you will reach the front of the SI joint. That is the trick. I have learned after 4 or 5 years how to follow that. That is the end of a SI joint. So I'm giving the trick, the how to reach. When you reach the SI, how to reach the SI joint. Because if you follow the operator nerve, you will be on the front of the SI joint. And one fifth trick I am giving you, that the operator vein is just following the operator nerve. And it's a very, very thin structure, it can bleed. Okay, but you will not probably, once you start bleeding, you will frighten. So take care of the operator vein. Okay, so this is the way how you take care. And this is the plate. This plate was not available in India. I have requested one company to make this plate. I think John might be knowing this plate is not available in India. So I requested one company, I made the template, and then it was made, and I have tried this plate for 1 year. Then it was launched in the market in last Kolkata IOCON meeting. This is the plate, right and left version is there, both infrapectineal and suprapectineal version is there. It was launched in Kolkata IOCON. So this is the plate we are using regularly for the infrapectineal or suprapectineal. Both the varieties are available from one company. So this is have the buttress from the medial side so that you can take care of your quadrilateral surface. So this is the way the plate is put, because we all, whenever we do the accidental surgery, probably the most part of the surgery is taken by the contouring of the plate. So this is the plate which is very, very beautiful, and these are got small, medium, the large size with the medial extension like your calcaneum plate. So it will take care of your quadrilateral surface with buttresses. You don't have to use that whatever we use, the radius plate, the bed 3.5 acorn. We are not using nowadays. Nowadays we are all using, whenever we are going from the front, we are using this plate. Then the repair is very, very simple. You just close the recti and this will take care. Okay. So I think if you follow the very, very basic things when you do this stopper, it is not a very dangerous approach. I think bleeding is much, much, much less. Even if you compare the bleeding with the KL, still the bleeding is not there with this is the, probably I will stop here for this just to show. This is the plate, how we use both the suprapectineal and the infrapectineal variety, because this was both the posterior fracture dislocation, so we approach from the KL approach, then we did from the front side. So if you follow the 5-6 basic things for your stopper, I think stopper is a very good armamentarium of those who aspire to become the pelvic acetabular surgeon like John, because John is one of my inspiration in trauma surgery. Thank you, sir.
Thank you, Sonendu, for showing it with clarity, all the steps. Well, only one inquiry, what kind of difficulties you encounter in repositioning the bones?
Yes, this is a very good question, sir. So when you go ahead with the stopper, because you have to use your ball pusher, and never use the ball pusher directly. There is a special plate, probably in the video it was there. You have to have a small plate sort of a ball sort of thing which can be attached on your ball spike, and because the medial plate is very, very soft. So if you just attach that disc on your ball spike, it will just put your things over there. And whenever you place that, you follow that you check that before putting the plate in the CR. Because you are very close. If you are not putting the CR in a proper place, probably your some screw might be intra-articular. So that is the base. Another one trick probably I have forgotten, I think John will be agree, that never put any screw in the psoas valley. Because if you put any screw in the psoas valley, that is 100% is going to be intra-articular. So never put any screw in the psoas valley. Another one trick in the stopper is that if you do the stopper, sometimes from the stopper, if you just reflect the superior fragment of your joint, you can see the dome impacts and fragment. So from there also you can disimpact the dome impacts and fragment. So this is another one trick. You can keep one screw free of the plate to create the dome, then buttress it like your tibial plate too, then put the plate. So this is the very finer aspect how you do your stopper. So I request you, because I think Mahendra is there, Rajiv is also there. So during the end of August, we are having the Kolkata meeting for the GOFCON. So I request all the delegates, all the senior members, I being the organizing chairman of that meeting, and Dr. Abhijit Bandyopadhyay is the organizing secretary, Dr. Rajiv Bora is there, Mahendra is there. I folded-handedly request everybody, please do come in the Kolkata GOFCON meeting. 26th, 27th, and 20. It's 26th, 27th, and 28th, end of August. Thank you very much for your kind and pleasant hearing.
Thank you, Samantha. Thank you for making appeal for attending next IFS con at Kolkata. This is end of October. Thank you.
Thank you, sir. There is slight readjustment. I would like to request Dr. A.T.M. Hall, sir, for his presentation. This topic is biological harvesting of fluorograph, a minimally invasive method. So, evaluation of sterilization procedure of habitual patellar dislocation. Not this one.
No, not this one.
Okay, Dr. Pal, you announce your topic and
My topic is actually the stabilization of the patella, the stabilization procedures of different dislocations of patella. Stabilization procedures of different dislocations of patella. So good evening, everybody, respected chairpersons, senior colleagues. Today my topic of discussion is a little bit different from trauma. That is the most common disabilities in the childhood, which is the dislocations of the patella. There are different dislocations of patella as you can encounter, and there are several factors as you can see here: the ligamentous factor, muscle factor, and the bony factor. Of which the bony factor is whatever the bony factor. There are different types of bony factor we can.
please maintain silence.
That doesn't change the treatment plan. Whereas the ligamentous factor and the muscle factor carries the heavy burden on management of the treatment plan. So depending on that, so we can differentiate the different types of the dislocations, recurrent dislocations, habitual, and the permanent. Recurrent, as you can see here, there are ligamentous laxity, but there is no super contraction. Whereas the habitual dislocation patella, there is a commonly, all of you know, there is a habitual dislocation patella usually seen in flexion, but now there is another entity is coming out. That is there is recurrent, that is habitual dislocation patella can also be seen in extension also.
That is maybe referred to the instability of the patella. Whereas maximally there is a medial instability is present, and there is a unique etiology which is described. There is a muscle, there is a localized muscle imbalance in a specific arc of patellar dislocations. Whereas in other cases, that is the habitual patellar dislocation inflection, as also in the permanent dislocation, there is always the superlateral quadriceps contracture. Along with that, there is some midlateral laxity. Both of that has to be sorted out. So this is the habitual dislocation of patella. As you can see here, there is a medial laxity of the patella. There are two problems, and both the problems, superlateral contraction on the lateral side, that has to be addressed, whereas the medial laxity of the patella has to be addressed on the medial side. And there is another entity that I described, that is a habitual dislocation of patella in extension. As you can see here, patella remains dislocated in extended position, whereas when in flexion, it is completely relocated in its normal position. As you can see here, if we see that this video, so there is basically see, in extension, the patella is dislocating, and whether in flexion, the patella is relocating. So, but that same time, same thing, when it is done on under anesthesia, it has there is no dislocation. So basically, it is seen that once a patient is awake, the patella remains dislocated once that they are in extension. Whereas the patient is in under anesthesia, it has not become dislocated. So this is it is under influence of the voluntary contraction of the muscles, and then there is a relative inability, relative imbalance, sectorial muscle imbalance during in especially 0 to 30 degree extension. So that will lead to this type of problem. Yes. See, it is, once it is flexed, it is in awake position, it is remains subluxated in extension, whereas in flexion it is completely relocated. This is the new entity which is it is not described in literature, and in literature what we have found in but after extensive search is the patellar instability. Okay, next video please. And same thing when we have done in under anesthesia, see, nothing is happening. That ignites the idea, and we have done this. So there must be some imbalance of the muscle power in vastus latalis and vastus medialis in the 0 to 30 degree of extension. There is associated bony defects and lax medial structure is also there. So, but that is the most important. As we have investigated these sort of cases by anteroposterior, lateral, and also some patellofemoral the skyline views. There are MRI shows the attenuated medial patellofemoral ligaments. There are several bony defects, but the most important, as you can see here, there's an electromyographic evaluation which is done at 0 degree at rest and after evolution. Whereas in the vastus medialis, the vastus latalis, as you can see here, there's a capital letter. In the 0 to 30 degree, vastus latalis contraction is much more than the vastus medialis. As also in the later part of the arc, vastus medialis takes the upper hand, this is the normal power, as in comparison with the vastus latalis contraction. So that is the indicators, that is some voluntary muscle power imbalance that is during this initial part of the extension. So there are several the procedures described in the literature, almost more than 100%, that most of them they have not consistent results, and because either their deforming factors may not be dealt with adequately, or the medial stabilization of patella has been reconstructed in such a soft tissue which is not physiologically strong enough. So we considered the restoration of the dynamic stability of patella by pace-sensitive transposition, which is described by Dr. Bakshi from long back. Means reported in 1991 in JDJS, in DBCT in 1993. Now I have become modified. There are several cases, that is 63 the cases of habitual dislocation pattern infection, and 7 cases so far we have treated the habitual dislocation pattern extension. So that is the majority of the female, and the common age of preponderance is the 9 to 17 years. There are several bony factors we have encountered, but most of the cases they are not significant enough. So they didn't require treatment till so far. Only one genu valgum, it is repaired later on.
Now, surgical options, there is a first is a superior contracture release, and there are several structures we encountered when we operated on the superior aspect incision. Then we started one by one, and once we cut one structure and flex the knee, and so that we have to see whether the patella remains in its patellofemoral group without any tension. So we cut one by one. So first, the lateral patellofemoral capsule is required all cases. Then the abnormal attachment of the iliotibial tract, if it is present in 40% cases, that has to be cut. In 4%, and there is a vastus lateralis is cut from all cases. Rectus femoris, and it is required in 60% cases, along with the vastus intermedius at the musculocutaneous junction to keep the patella in its patellofemoral group without tension. And the pes anserinus transposition, 3/4 pes anserinus transposition, not the whole pes anserinus. So 3/4 attachment of the pes anserinus, it is transferred to its close to the medial border of the patella and its ligamentum patelli and is repaired. Now, this is the operative technique. As you can see here, there are double incision technique. As you can see here, this is the lateral, the dislocated patella, and this is the operative approach. And the vastus lateralis is cut after the incision on the lateral aspect of the patella. After cutting the lateral capsule and the retinaculum, vastus lateralis is taken out. And after every step, I repeat, after every step, we flex the knee and to see whether the patella remains in this patellofemoral group without any tension. So after vastus lateralis, if it requires, the rectus femoris and vastus intermedius is cut at this musculotendinous junction. It is completely flexed, and now once we have satisfied that patella remains in this patellofemoral group, then we repair the cut end of the vastus lateralis to the cut end of the rectus femoris, whereas the cut end of the rectus femoris and also medial aspect of the vastus medialis is repaired to the lateral border of the vastus lateralis, so that the whole of the quadriceps spool is medialized. So this is the most important. That is the classical technique of quadriceps plasty. And the pes anserinus transpose, as suggested by Professor Bakshi, it is like a V-shaped manner. It is just become a inverted V, and is only the vertical suture is applied on the medial aspect of the patella and the ligamentum patelli. Now I have modified this technique. So what we have done, you see, this is the similar technique we have used this. And after taking out, so what we have done, so actually the superior edge of the pes, as you can see here, superior edge of the pes is stitched with the overlap lax capsule of the and retinaculum. This simulates the restoration of that is the medial quadratus tendon femoral ligament, as also the MPFL. See, there is a there is a horizontal suture as also the vertical suture. Same V type of is a part of the pes is elevated, is priced up to become stitched over there. And see these two, but this vertical suture as also the horizontal sutures. Once it is completed, both the suture ends is passed to the oblique tunnels through the patella and to be stitched on the other side, so that it remains attached to the patella. This is the modification. And so this is the horizontal suture and this is the vertical. So this is the modification. Initially, the classical is only the vertical. I have already this vertical, this horizontal suture is added by me. So post-operative care, post-operative cast applied with knee in extended position. Change of dressing is on the 8th day, and the removal of the stitches is done on the 14th day. Removal of the post-operative cast after 5 weeks, knee bending and the quadriceps exercises started subsequently. This is the case. It's a 12 years old boy presented with habitual dislocation pattern inflection, and this is the 10 years follow-up starting extremely good results. This habitual dislocation is a maximum follow-up. This is a 9 years old girl presented with habitual dislocation pattern inflection. This is a 1 year follow-up, and this is a 21 years follow-up. This is the highest follow-up in our series. It is did by this classical technique, and the result that there are extremely good results, excellent good results in most of the cases. There is 18 years follow-up of the modified technique of this pes plasty, as you can see here. See, so these are extremely good results of the modified pes plasty, and special particular of this case is, so there is a high there is a high Q angle. So in spite of the presence of the Q angle, so see, the Q angle is so high on this the affected side, but still it is not become recurrent. This 18 years follow-up. So Q angle doesn't make a contraindication on this. So results of habitual dislocation pattern in its modified test, 7 among the 7, there are all excellent results in 2 to 5 years follow-up. So what is the cause underlying these successful results? There is adequate supralateral contracture release and the dealing of the weak static as well as the dynamic factors on the medial side by the modified pes anserinus transposition. So it is explained anatomically as the base sensor provides the broad base anchorage, so there is no stretching or the attrition rupture. Physiologically, at the same time, it has an active sling since its nerve and blood supplies of the proximal muscle fiber remains undisturbed, unlike the Galeazzi technique or the other technique where we took the free tendons. Electromyographically, it is a space seismic activities continue throughout the range of flexion, especially during the 30 to 90 degree of flexion of the knee, which proved electromyographically where the habitual patellar dislocation usually occurs. And the biomechanically, inferior tendons of the place seismic, as you can already show, is moved to the superior position. So in extended knee, this new tendinous insertion is actually appears as a V angle, inverted V angle, and on the when the knee is flexed, the knee angle is straightened. There is a direct medial pull on the patella. And this is the most important. See the horizontal stitches of the stimulus simulus, this reconstruction of the medial quadriceps tendon femoral ligament, as also the MPFL reconstruction. The same technique as you can see here, whereas in the vertical stitches, the sling is placed diagonally opposite to the deforming factors of the contracture, so it is mechanically effective, effectively counteract the deforming forces. Not only that, in the long run, it shows it can alter the retropatellar pressure as also the contact areas, and it is applicable in all ages. Before epiphyseal closure, patient with the hypermobility, where there is an MPFL reconstruction, the result is very poor with the hypermobile patients with generous medial laxity, and this space is also effective in older patients. So conclusion is adequate suprarenal contracture release in habitual and permanent dislocations and modified place as transposition as an effective medial stabilizer of the patella and effective procedures for all type of habitual dislocations. There are several publications, and this modified technique is also under publications. Thank you.
Thank you, Dr. Pal, for elucidating very clearly the various types of dislocation, recurrent dislocation of patella. I would only like to know that you have distinguished dislocation in extension, dislocation in flexion. Same pace and insertinous transposition will perform for both the cases?
Yes, sir. So I've already told, say the habitual distal pattern, flexion and extension, the common factor is the muscle laxity, medial soft tissue problem. But along with that, in habitual distal pattern flexion, there is a suprarenal contracture. So both the medial the soft tissue problem is the common. So simple base anseriness, which is a modified form, where this combines both the medial the downward pull as also the medial pull, that can take care of both the condition.
As Dr. Pal sir have to leave, so any question on this topic? I would like to have one question, sir, particularly in that waste transposition, which I have encountered. There is some flap in the process problem because there is a lot of undermining of this flap. So, what to?
Yes, it is a very valid and practical questions. In our previous life, we experienced this sort of problem. There is a constant leader which is directly goes inside the proximal tibia just underneath the face. So that is the special technical tips is once we give an incision on the inframedial aspect, we should not undermine the skin flaps. We should the full thickness skin flaps directly go to the base anserinus, and whole the base anserinus should be elevated along with the periosteum. And once after that, still there is some possibility of bleeding point that has to be taken care of. Otherwise, if there is some collection of the bleeding point, this is absolutely right. There is a problem. If there is a collection in postoperatively, so if there is a doubt, we can give some drain also. This is most important. And compression bandage to take care of. Otherwise, there is a problem of skin. Yes, right.
One more question to Pal sir and Johnson. Sir, is there any mode of trochleoplasty and that CBT transfer?
More than trochleoplasty, what you very often have to do is a medialization of the tibial tuberosity. And today we do it slightly differently from the original procedure that we also anteriorly transfer it. So in this procedure, because you make an oblique osteotomy, it becomes anterior also, doesn't go posterior if you make a horizontal osteotomy. Okay, because the medial surface of the tibia is horizontal. Trochleoplasty in cases of severe trochlear dysplasia, that is the only situation where you would need to add a document. So, and MPFL reconstruction is what we will do for a lot of the post-traumatic ones, because there the medial patellofemoral ligament has gone. So I think you need to add that. So we don't use this particular method, but we use the combination of these. So we use the MPFL to strengthen the medial side structures.
So that semi-rerouting.
Yeah, so that's using the semi. Yeah.
Yes, sir.
So we don't do, it is not a rerouting, but you actually do a graft and a MPFL reconstruction through the isometric point in the medial femoral condyle.
Regarding the trochleoplasty, we have encountered there are several 2 or 3 cases of severe trochlear dysplasia in pediatric age group, but surprisingly, in the long run, it has become modified. Once the patellar tracking has become rectified, and this is also supported by several studies, the trochleoplasty in the pediatric age group, especially before 7 to 8 years age group, there are 2 remodeling processes already there. So trochleoplasty is not required unless it will be older patients.
We will do it only in the older patients.
Yeah.
Okay, so we have done only, so all these years we've done only 2 trochleoplasty. But we've done a lot of these and in the child we do the Google plate procedure. We don't do a tubercle medialization, but you take off half of the tendon and medialize that half of the patellar tendon under the periosteum on the medial side. So that's how you change the direction of the pull of the quadriceps.
With due course of time, it remodels well.
Dr. Gaurav, you want to say something?
Regarding the horizontal suture, sir, you are putting through the patella or
no,
not
I've already showed there's a horizontal suture and the vertical. Vertical suture is the classical one. The horizontal suture, we actually bolt both the lax capsules, drag it down, and undermine the upper edges of the patients under this lax capsule and retinaculum, and they just turn it. And once it is done with both the free ends of the suture is passed through the oblique tunnels of the patella and repaired on the other side. So that is the technique.
That means tunnels in the patella.
Yeah. I mean,
but in case like this type of cases, the patella is dysplastic. Sometimes the groove also is shallow. Like there is not.
Doesn't matter. Doesn't matter. It will, if you do very earlier period, it will remodel well. That is classically it is supported by literature.
Thank you.
Thank you, Dr. Pal. Well, friends, I interrupt here to welcome Dr. Usha Sharma, wife of our very own Dr. Vijay Narayan Singh and his daughter. Madam, we welcome you. It's a sentimental moment for us. Thank you for coming here. Thank you very much. Now we can continue with the next speaker.
Thank you, sir. Now I'd like to invite Dr. Rajiv Chutral, and his topic of presentation is periprostatic fracture around knee.
Thank you once again. It's again a little too little time to talk about all periprostatic fractures, so I'll just try to make the best of it. We know that joint replacement surgery has become very commonplace. A lot of orthopedic surgeons are now going into joint replacement, doing them. So we're going to see a lot of fractures, and we're going to see a lot of problems with those fractures as well. But what has to be differentiated is, number one, whether you do this fracture during surgery or you find it after surgery. And there are totally different ways to treat them. And also, where is the fracture? Is it only in the femur? Is it only in the tibia? Is it also in the patella? Is it also everywhere? So the incidence, if one looks at the latest reviews, talks about the highest incidence of post-operative fractures occurring in the femur, and you already know that. But in revisions, you can see that it happens mostly in the tibia or in the femur, and there are really tough decisions what to do when you have a revision total knee or while doing a revision total knee. The risk factors, clearly these are patients who are older, who are sometimes on long-term steroids or other anti-inflammatory drugs. They already have inflammatory pathology. They may have neurological disease. They are diabetic, sometimes obese. And when you're doing the revision, I told you, you are at particular risk for having a fracture. So intraoperative fractures first, they occur either during your preparation or during the implantation. The patterns usually minor, they're not displaced so much, they're not comminuted unless you've got a very, very strong person who is hammering the implant. And the components are usually stable. Of course, if you have an unstable component, you have to take it off. You have to fix the fracture and then put in a revision kind of a process. So we always keep the inventory of revision implants with us on table when you're doing a primary. patient who's got multiple comorbidities, suspecting some possible fracture that might happen. So treatment for these undisplaced or minimally displaced fractures usually involves some form of fixation of that fracture fragment back in situ, so either a screw or sometimes a circular wire, and the rehabilitation more or less proceeds unaltered. So fractures like this, for example, where you already bypass that fracture with a stem, you can proceed with normal weight bearing and early mobilization. On the femoral side, screws and washers are usually supplemented. These fractures happen usually when you're preparing the box, if you're using a PS knee. And sometimes when you're impacting the final implant with cement and the bones really hard, it can cause this crack going up into the shaft. So you can manage with just screws and delay or weight bearing, but if it's terminated, then you have to, of course, use a long stem. If you have bone graft, which you have right there with you in the primary, you can fill the defect and patch it up with those cancellous chips that you got from the bone ends, and try to avoid cement extrusion into the fracture pattern. And of course, then the weight bearing should be delayed. In the tibia, you can have it because of stems which are impinging into the cortex if using a very thick uncemented stem. So as a rule, try not to use a thicker stem, but try to use a thinner stem which will provide some form of rotational and axial stability. Whereas vertical splits are usually well approximated, and simple screws and protected weight bearing can work. So intraoperative fractures are pretty much easy to treat when it concerns the tibia or the femur, but the patella is a different ballgame. And if you're trying to resurface a thin patella in an obese patient or try to invert this patella in a tight knee, you may cause either an extensor mechanism rupture or a patella fracture, and that, trust me, is a nightmare to treat. If it's a vertical fracture, they are stable, no surgery is required, but if there are transfers, you can attempt tension band wiring, but the rehabilitation is delayed, and thereafter, you may end up with joint stiffness or restricted range of motions. If the fracture is stable at 90 inspection, you're okay, you can get away, but if it's not, then you really have problems. Even the best tension band wires can actually fail because you don't have much bone left to actually get fixation. So in post-operative fractures, however, it's a totally different mechanism. There is, of course, a unified classification system which we use today to identify and classify these fractures. And this is a very good mnemonic, where type A is apophyseal fracture, which are not related to the implant directly. Type B is at the bed of the implant. C is just clear of the implant. D is dividing one bone, I mean, basically on both the sides of the joint. E and the F is, of course, which is on the opposite side, like a bipolar or a monopolar hip replacement, and you cause a fracture of the abdomen. So, post-operative fractures on the femur, there's a little debate on whether notching causes it, but it's proven without doubt that unless you have severe notching on both medial and lateral femoral suprafemoral region, there will not be any increased risk. The problems in this case are loose processes, and whether you have enough bone distally to actually get fixation, and then whether you use a nail or you use a plate, you must align the limb properly, you must reduce the fracture and get adequate purchase so as to allow early mobilization. So osteoporosis is a big concern here. We use the Roller-Lewis classification, and sometimes you need to do a CT scan to check whether the implants are actually holding and they're stable or they're loose, because that changes different options. We know, for example, the external fixation is bad, and you only do it as a temporary method, but you have to either go for a nail or a plate with some fixed angle device, and sometimes a double plate. And whether you do it through an open procedure or a biological procedure, as long as you have adequate purchase in the distal fragment, you can get a good result. But there are complications that can occur with this, because sometimes you have a similar sort of implant lying proximally in the hip, whether it's a DHS or it's a PFN or it's a total hip or a bipolar, and that may sort of limit the amount of length of the nail that you can get to, or you may have to use a plate, and you can get loss of reduction, or you can get delayed union or non-union sometimes. So to salvage, you can actually combine internal and some form of circlage with a nail or the plate, or sometimes you may need to do what is called the distal femoral replacement processes. And there's an algorithm which we guys published in the Indian Journal of Orthopedics in 2015. I'm happy to take any mails from you guys if you want to know how we sort of treat these fractures and how we divide them. So remember that in the distal femur, there are a variety of options, whether you want to use a long plate, or you want to use an open reduction, or you want to use a nail, or you need to do a distal femoral replacement. Tibia, on the other hand, there's cancellous bone and it can easily fracture, and sometimes you may have loosening, but most times you don't have loosening of the tibial implant unless the fracture goes under the base plate, and these can be fixed Sometimes they are missed. You need CT scans to diagnose them. The classification is by Felix, which we follow. Again, the external fixation is bad, but you can fix them with screws, wires, or plates, and then of course use grafts and sort of bypass it with some stents if required. Again, there's an algorithm for fixation of tibial fractures post-operatively, and this can be seen easily on the net. Patella is a difficult problem to treat, but luckily post-operative fractures can be managed relatively easily, even though they have risk factors. The basic treatment depends on the location of the fracture, the pattern of the fracture, and how good is the extensor mechanism, and of course, if you have a stable implant or not. So you have different patterns of fractures, and if you have a stable implant with an intact mechanism, it's very easy to do. You can do it conservatively, but if you have a stable implant with a disruption of the extensor mechanism, you can just proceed with a normal tension band wiring. If, however, the implant is loose and you are a little stuck, you may have to remove the implant and just fix the remaining fracture with some tension band principle, and sometimes also supplemented with a detensioning stitch. So there's an algorithm for that as well. Interprosthetic fractures need a combination of techniques, as you can see. But the take-home message is that the intra-op fractures are stable, they can be treated with screws, and you can delay rehabilitation, weight bearing especially. The supracondylar fractures in the femur are the most common. They need fixed angle devices, nails where possible. Tibial fractures can need a long semi-condylar fixation, and patella is relatively easy to manage. Thank you.
Thank you, Rajiv. Well, friends, complications can take place on the table, but they are all salvageable. And so the message is that you have to remain prepared. My only suggestion would be that if you can better make a pre-operative assessment of the patient, especially in the light of existing osteoporosis, and that you have rightly pointed out that osteoporosis is one factor which should have been treated earlier, or maybe you will treat them later. Thank you. Thank you very much for all the complications.
Dr. Rajiv. So our next presenter is Dr. M. Aziz Kumar from Mangalore, and his topic is non-union femoral shaft fracture.
Dr. Rajiv.
Respected seniors and dear friends, I'm talking on a fairly common topic. Most of us encounter non-unions of femoral shaft fractures, but I think each of us approaches these fractures in our own ways. Even in the literature, there is not much of recommendation. I think in the West, the general trend was for exchange nailing. They would do exchange nailing 1, 2, or even 3 times. But in our scenario, we cannot go on doing those sort of procedures because our people are the sole breadwinners most of the time. And economically also, it's a huge hit to salvage this problem. So this is what the literature says, that there is a 96% incidence of union following intramedullary interlocking nailing. But I think this is mainly applicable to the mid-shaft, subischemic and shaft fractures. Whereas if you go further down or proximal, where the femoral shaft flares out, then you get much more incidence of non-union. This is a challenging situation because of various factors that are involved, and it leads to a lot of morbidity, limp, multiple surgeries, sometimes which ends up with infection as well. So it can be a disaster in that count as well. And so it's most of the time young breadwinning individuals. So the whole family is facing ruin because of this problem. Yeah, most of us are aware of how to diagnose this. I don't think I need to go through that. But sometimes our own cases we tend to delay. You know, we think that it's going to unite, whereas with some other person's case, we may probably be a little more aggressive in managing that case. But the important thing is you need to intervene in time before the implant breaks, because once the implant breaks, then it's a much more daunting scenario to extricate yourself and the patient from that situation. So if the patient is unable to weight bear without aid at about 4-6 months, then you know that you have a problem at hand, and I think it needs to be dealt with at that stage. So what are all the ways to deal with this situation? In the early era, I think when we had the puncture nail, most of us would have removed it and put a plate fixation, plate with bone grafting, because we were in the age of rigid fixation of the AO in that time, in that era. After the interlocking intermedullary nailing came in, exchange nailing has been the most applied principle, with or without bone grafting. In the West, they don't recommend bone grafting so much, but in our situation, most of us do practice bone grafting as well. So another technique is this augmentation plate fixation, which was first described by the Koreans way back in 1997. But we were a little slow in adapting that procedure. But as I can show you, it gives excellent results. So basically, the problem could be either biological or mechanical. Biological in the sense, if it is a comminuted fracture, if it is an open fracture, or if the patient has comorbidities, then the healing is inherently poor. And mechanically, if inadequately fixed or a thin nail has been used or a very short nail has been used, these are the ones that we need to look at. So all this, yeah, like I was telling, way back in 1997, Ewing et al. From Korea described this technique of augmentation plate fixation, and they did not remove the implant. They just went in and put a derotation plate, and they had excellent results. Whereas for us, the patients come in late, and we have a lot of issues with that. So nowadays, plate osteosynthesis is not a very well accepted thing for exchange after removing the nail. Most of us do put in the nail again and bone graft it, or put in that along with a derotation plate. So just run through a few examples. Here's one 64-year-old gentleman, subtrochanteric fracture with a large butterfly fragment which failed to unite in the appropriate time. He was having problems. And what we did, we exchanged nail. What you need to see is by increasing the diameter, by reaming more, you are producing more material for osteoinduction. And these have healing properties, and so they help as well. But in this particular case, I also bone grafted and put in a lag screw there for whatever additional stability that it gives. And that went on to heal. And that's his full range of movement that he had at that time. So here's another situation. Ipsilateral trochanter with shaft failed to unite because, as you can see, the nail is a little short and only one screw is there in that distal segment. So it did not unite, not surprising. This went on to undergo rigid fixation with compression plating and bone grafting, and he went on to heal well. Very rarely, most of us do this technique nowadays, is at the time of plate removal. Most people nowadays, I think, go in for, again, another situation, thin nail, single screw distally, obviously in a flared out distal femur, it will fail. And so exchange nailing with augmentation plating with bone grafting. You can say this is probably a little too much, but our patient cannot afford to undergo a third procedure. So belts and braces technique probably is what is recommended here. This is a very young patient, 17-year-old, 1 year post fixation, not going on to healing, and then exchange nailing with augmentation plating. So she was not consenting for iliac crest grafting. So we used RIA bone graft and fixed it. This was a poorly done nailing from elsewhere. Probably they had a lot of issues in drop because, as you can see, the entry point itself was wrong, and they fractured it at multiple levels. And it was no surprise that it went on to not unite. So exchange nailing with a better entry point, we use that reaming material as bone graft and put in a plate to derotate or avoid rotation at that particular point, and went on to heal well. She was a nurse working in one of the hospitals, and she did well. Yes, you may ask that the plate is very long. because we don't get enough purchase, so we didn't want to take a chance, and she did well following surgery. Another case, as you can see, thin nail, and at the lower fourth junction, the broken piece we could not remove. We could not remove the proximal part, so we left it there and plated and compressed there and bone grafted it. And it went on to heal well. So I think the diamond concept has been described. You can look up the literature about this. It's basically talking about providing a good interior milieu for fracture healing. So the take-home message is it's a challenging problem. In ischemic non-union, only exchanging nailing may be enough, but in just one moment, sir. Above and below the isthmus, rotational instability, you need to add on a plate to give a early successful result. Thank you very much for your attention.
Thank you, Dr. Ajit, for a very clear presentation on a very common problem. Well, I just wanted to know, have you met across situations where the nail or the transfixation screws, they have failed and the fracture has united?
Yes, sir. There are instances where the nail has broken even after the fracture has united. Certain situations we have had that also. Certainly what you mentioned, we do have seen that. It has gone on to heal. Many times the patients just rest at home. Some surgeons have even provided a thigh brace for these people, and they have gone on to heal, sort of a delayed union, you could say.
And but for the mechanical failures, periparatype sometimes can be a good aid in promoting union.
In osteoporotic individuals, yes, sir. That's also recommended. I didn't get all the latest literature. People talk about that, but practically, I think for average practicing surgeons, this is a good way.
Dr. John, you want to make a comment?
To be careful with periparatype. It's a treatment for osteoporosis. So where you think the bones are so soft that you are worried about an implant holding, yes, there's an indication. But it's not an indication to promote union. Okay.
But for the mechanical failures.
Thank you.
Any question on the
Any questions from the audience? Like you can wind up.
Sir, I have one question. Sir, this is regarding the dilemma of choosing the implant. Sometimes what happens, I have encountered particularly in open cases, primarily nailing was done, and somehow delayed union and non-union occurred, and some amount of periosteal reaction is there. ESR is raised. On those cases, in few cases which I have seen that nailing was done, and there was flare up of infection, then ultimately we landed up with LRS. So prior hand can we choose implant where rather than going for re-nailing, we can directly go for some external fixator kind of thing. I have encountered in a few cases. That's why
I think you're talking about a scenario of open fractures.
Primarily done. Okay.
Yeah, I mean, in the femur, unlike the tibia, if you debride thoroughly and nail it day one, there's usually not a problem because there is good amount of blood supply there. I think even finally it boils down to the quality of your debridement. If that is done well, or if the patient doesn't come late to you, then I think it's the best way to go. But certain situations we have seen during COVID era, people have come after 4 days, 5 days with puncture wounds who have got infected. That has been a real challenge. And I think there you need to treat it very aggressively, like with radical debridement, and then take probably an informed consent and going with nailing. My preference would be to nail these fractures because I've had a lot of issues with pin side problems when I put them into external fixator with type 2 or even type 3 open fracture femur.
I think his question was more related to unrecognized infection in a non-union.
Yeah.
So when someone's had a nailing done and he goes on to non-healing and then you do an exchange nailing and then infection test. So you have to make sure that you rule out infection and always, in spite of whatever clinical and tests and lab tests you do, sometimes you may still have infection. So you need to warn patients about that. Okay, it's important. In any redo surgery, there is a risk of there being infection which may have already been there or is a result of your surgery. So that's something you always have to be careful of.
Particularly diabetics.
Yeah.
Thanks.
Thank you very much. I thank Dr. Satrughn Ram for being associated here this afternoon. Thank you.
So we'll switch over to our next session, Dr. V.L. Singh oration. And chairperson to this session is Dr. Manoj Chaudhary sir and Dr. Saraf sir.
Now, it's time for the prestigious Dr. V.L. Singh oration. ये भावनात्मक क्षण है। मैडम भी यहाँ बैठी हुई हैं, सुप्री जी भी बैठी हुई हैं। ये बहुत भावनात्मक क्षण है जो V.L. सिंह जी हम लोगों के इतने करीब हुआ करते थे। उनका ओरेशन है and the oration will be delivered by none other than Dr. Ajay Kumar, the famous diabetician. He is MD, MRCP, and he was the organizing secretary of GOFCON. So I shall request Dr. Ajay Kumar ji to kindly come over the dais. Sir.
Welcome to you all in this session. Now I call Dr. Amulya for recitation. First, Dr. Archana. May I call Dr. Archana?
Dr. Archana Singh is the daughter of late Dr. V.L. Singh, and she is in the All India Institute of Medical Sciences. So, Dr. Archana Singh, please come over the dais. Doctor.
This is a really emotional moment for me, and I don't think I'll be able to say too much, but I'm sure Dr. B.N. Singh, my father, was more than just an orthopedic surgeon to you. However, we would, on behalf of my mother too, try to communicate that we are very humbled and very appreciative that in this forum, you have chosen to name an oration after him so that my dad's lifelong association with orthopedics and his lifelong contribution will be remembered in some measure through this oration. Thank you.
I shall call upon Dr. Ajay Kumar ji
It's a proud moment for all of us. Yes, a guardian, a father who blessed all of us. First time when I saw him, it was 1994. I was in Patna Medical College Hospital as a postgraduate student. There I saw him. He had come over to teach some of the PG students. And when I looked at him, the personality, the grace, what this gentleman, late Dr. Vijay Narayan Singh sir, had. An aura, I will say, and I had a chance to work with this magnanimous personality as the Secretary of Bihar Orthopedic Association when he was the President of Bihar Orthopedic Association. And we were awarded the Best Chapter Award in India. Bihar got it under his leadership. And now for the oration, I could have thought of some names, but there is one person in Patna only with whom I had a chance to be on stage at two places, once in Jamshedpur, we traveled together, and once at Hazaribagh. I can't believe it. A man who is so respectable for so many of us and everybody, the medical fraternity. The way he communicates, the way he expresses, but he has love for all. Sir, Dr. Ajay Kumar, sir, you are the best person to tell us in medical field. But at present, I would like to felicitate you. Can I have a bouquet with Dr. Ashan Saraf will present to him? This is a chocolate bouquet. Dr. Manoj Chaudhary, sir, please come forward. And Dr. Manoj Chaudhary, sir, please a shawl to Dr. Ajay Kumar. And we have got something for you on behalf of Bihar Orthopedic Association, Global Orthopedic Association. Global Orthopedic Forum is privileged to acknowledge your illustrious career as an eminent consultant physician and diabetologist whose career is worthy of emulation. You completed your MD in medicine and then FRCP from Edinburgh. The Diabetes Care and Research Center Patna is a famous institute of which you are the director and where your expertise has given much secure. Your service as the principal investigator of several phase 2 and phase 3 studies in development of new molecule in diabetes is indeed commendable. You have been the principal investigator for ICMR India-B study on prevalence of diabetes and pre-diabetes in India. Your academic status has been highlighted by your extraordinary long list of services, such as being the global expert for development of newer insulins and GLP-1 based therapies and the global expert for the premixed insulin guidelines. You have been conducting for several pharmaceutical companies, and friends, I must tell you, he has authored several chapters in textbook of diabetes and medicine, which are very well accepted in medical fraternity. Many of your research papers have been published in internationally renowned peer-reviewed journals. You have delivered more than 1,000 lectures at national and international conferences. We are intensely proud of your academic and professional success and pray for your long life in the service of humanity. And we feel honored in presenting you a citation on behalf of Global Orthopedic Forum and Bihar Orthopedic Association. And who better than my guardian, Dr. Usha Sharma. Please come forward, ma'am, and present this citation on behalf of all of us.
to Dr. Ajay Kumar, sir.
Before I present the citation, I congratulate Dr. Amulya Kumar Singh for organizing this grand conference and selecting Dr. Ajay Kumar for the oration, who is a world-famous physician in diabetic care. I feel honored to be presenting this citation to him.
Sir, Dr. Ajay Kumar in front of you.
Honorable Chair, ladies and gentlemen, the smile tells you all. This is the infectious smile with which we lived for the last 3 decades. I really feel very emotional when I talk about Dr. Vijay Narayan Singh. And before I deliver the scientific part of my oration, let me quote a Persian couplet for Dr. Vijay Narayan Singh. याददारी के वक्ते जागने तो जुमला खंदा सबंद ओ तो गिरिया, which in Hindi translates कि जिस समय तुम जन्म ले रहे थे उस घड़ी को याद करो, तुम रोते हुए आए थे और सारे लोग हंस रहे थे। याददारी के वक्ते जागने तो जुमला खंदा सबंद ओ तो गिरिया, आंच नाजी के वक्ते मुर्दने तो जुमला खंदा सबंद हो तो गिरिया। ऐसी जिंदगी जियो कि जब तुम जा रहे हो तो तुम हंसते हुए जा रहे हो। That was Dr. Vijay Narayan Singh. When Amulya asked me to talk about diabetes and orthopedic, it was a very difficult challenge for me to actually think, what should I talk? And if you look at the skeletal complications of diabetes, and I am a very small fry to talk about fractures in front of a galaxy of orthopedic surgeons, but look at the spectrum of the fractures, whether, from left to right. You can see the distal radius, the proximal, the subcapital humerus, the proximal femur, the vertebral abnormalities. Then on the lower panel on the left side, the Charcot-arthropathy, and then we have the pseudoarthrosis, periprosthetic fractures leading to implant loosening, and the entire spectrum of osteomyelitis. All these are very common complications for a diabetic patient, he or she who enters into an orthopedic clinic. And why are these outcomes so horrible? For this, we have to understand that type 1 diabetic children, who of course have the right to grow into adulthood, and now type 1 diabetic children actually live till the age of 75 and 80 years. Type 1 diabetes patients have got low bone mineral density, and therefore they have a 5 to 6-fold increased risk of fracture. But contrast that with patients of type 2 diabetes who may have normal or even increased bone mineral density, and yet they have 3-fold higher risk of fracture. I'm not castigating the use of bone mineral density as one of the investigating tools in clinical practice, but it's only to tell you that we should not be led to complacency by just looking at the bone mineral density of a diabetic patient. It may be normal, it may be increased, yet there is an increased risk of fracture. Postmenopausal women, same thing, with normal bone mineral density have got a much higher risk of fracture. All these factors have to be taken into account. But when you made such statistical statements, you also need to explain that what is the scientific reason behind this happening. Now, on this picture, what you clearly see is, on the left-hand side, a person with a healthy bone, and contrast that on the right-hand side with the bone of a diabetic individual. There are a few things which will clearly strike your attention. And I think the first thing that if you look at the number of the osteoblast cells in a diabetic patient, can I use this? Okay. Now, if you look here, look at this, osteoblast cells here in a normal individual and compare that with a diabetic individual. Clearly, there is a marked reduction. When you look into the bone marrow of a diabetic person, it is full with this adipose tissue. There are final prints which tell you the mechanism as to how this happens, but it certainly gives you a lot of idea as to how can you improve these things. Pro-inflammatory macrophages. Look at the difference. This is the normal bone, and these are the bones of a diabetic patient. There is a remarkable increase in the pro-inflammatory macrophages. Less number of osteocytes. Here you have the normal osteocytes, and this reduced number of osteocytes will lead to reduced bone turnover. And then you have also the endothelial progenitor cells, which actually give you the opportunity to develop more and more adult bone cells. There is a remarkable decrease in those cells. Obviously, all these are translated into increased risk of fracture, increased porosity of the bone, and that explains as to why that irrespective of the bone mineral density, diabetic patients have an increased risk of fracture. In the earliest stage of the interaction between diabetes and bones, I think we have to appreciate that beyond uncontrolled hyperglycemia, we have the issue of obesity. And look at its direct impact through the mechanical loading, and then obesity is a pro-inflammatory state. And because of this, you have once again the pro-inflammatory milieu that is affecting the bone that will further increase the risk of fracture. And then we have a whole lot of metabolic milieu that we are talking about. And as the diseases progress, you have the reduced bone strength, accelerated aging, now the microvascular complications set up. And the most dreadful thing is the advanced glycated end products. If you have uncontrolled diabetes, it ends into complications, and every cell of the body is deposited with advanced glycated end products. And that accelerates the process of damage to that particular tissue. There is a huge spectrum of diseases when we talk about bone and joint in patients of diabetes. But there are few, and time will not permit me to go into the entire gamut of this discussion. But few of these, the fibroproliferative disorders of the soft tissue, I think almost 15 to 20% of patients of diabetes come to me with one and single complaint, and that is shoulder pain. This is so common. Then you have the issues of joints, you have the issue of bone. All these are extremely important. This is being highlighted for one simple reason, that whatever the age of the patient may be, whatever the bone mineral density may be, diabetics have to be taken very seriously by orthopedic surgeons. And when an orthopedic surgeon refers a patient for good control of diabetes, the diabetologist or the physician has to be extra cautious about it. There are a number of drugs with which we treat our patients of type 2 diabetes. They are the traditional ones like sulfonylurea, these DPP-4 inhibitors, GLP-1 receptor agonists. As an orthopedic surgeon, you must know what is the effect of these drugs on the bone health. Why am I telling you this? That everybody is very busy. You are very busy. I am also very busy. Each one of us is very busy. And what happens that I prescribe for good control of diabetes, let's say a metformin and a pioglitazone. At some stage, the patient sustains a fracture. Now, I have forgotten after prescribing these two drugs, but we know for sure that pioglitazone increases the risk of fracture. All the thiazolidinediones, rosiglitazone is now banned, but pioglitazone is still extensively used in clinical practice. So at least when you are discharging the patient, tell the patient to go back to your diabetologist and ensure that furthermore, this patient should not be prescribed the pioglitazone. So when we look at the list of these drugs, the DPP-4 inhibitors, sulfonylurea, SGLT2 inhibitors, what are their effects on the bone mineral density? And more importantly, what are their effects on the risk of fracture? This has to be understood. And in the entire list of the drugs, there are lots of confusion also. Sometimes you have one set of data which tells it's a neutral effect. One set of data tells you that an increased risk. But one thing is very clear, and I will not take a lot of your time. This is about insulin. This is absolutely clear that TZDs, the pioglitazone, definitely increases the risk of fracture. And also it's very clear that metformin is one drug which is very healthy for the bone. And therefore, metformin is one drug which can be safely prescribed to every patient of type 2 diabetes, irrespective of the bone health that we are talking about. But do we have a drug which actually has a positive impact on the bone health? Metformin may have neutral effect or some positive impact. But now the latest drug, the GLP-1 receptor agonist, and I've been very lucky to be involved with the development of most of the modern GLP-1 receptor agonists at my center. Almost every single GLP-1 receptor agonist have gone through the phase 3 clinical trials of my center in Patna. Now, this is one drug which has clearly a positive impact on the bone health, and therefore it should be used extensively in clinical practice. Unfortunately, at this point of time, it's a little expensive, but it has caught the imagination of the physicians, diabetologists all over the world, and at least in the western part of the world, where cost is not a very important issue, this drug is very extensively used. Not to say that it's not used in India. In India, also in the metropolitan cities, it is used right, left, and center. How does it work? I talked about the problems related with the increased fracture risk in type 2 diabetes. These GLP-1 receptor agonists, actually in the osteoblast, they increase the production of osteocalcin and alkaline phosphatase. And in osteoclast, through the upregulation of calcitonin production from the thyroid C cells, they affect positively into the bone health. And therefore, it would be imperative on the part of all the physicians that GLP-1 receptor agonists should be used very frequently in clinical practice. And the good news is that now one company has come with oral GLP-1 receptor agonist, semaglutide, which is going to be launched in 3 months' time in India, and that will be a game changer for the practice of diabetes in clinical practice. These were the parts of my talk which were related more to diabetes. Now I will talk more about your practice. When a patient of diabetes or any patient comes to an orthopedic emergency services, what are the pattern of glucose abnormalities that we actually see? Now, this is a global data which very clearly tells you that 38% of these patients will have some sort of hyperglycemia. And what is important is that a significant proportion of these will have the first time diagnosis of hyperglycemia. These patients will give you the history that I never had diabetes. I don't know, your blood test is showing that my blood sugars are raised, but basically I don't know that I am a diabetic. And then you have another percentage of patients here who have known history of diabetes. And of course, these 72% of the patients are normal. So what are you going to think about these 38% of patients who come with some sort of hyperglycemia? And you will be led to believe that those patients who have a known history of type 2 diabetes would have a more adverse outcome in your orthopedic emergency. But that is not the case, unfortunately. If you look at the mortality and the outcome in non-diabetics, non-hyperglycemic patients, of course it is very low. But patients with a history of diabetes are not too bad. The worst patients are those who only have the first documentation of hyperglycemia at the time of admission. And therefore, you should not take lightly the first diagnosis of hyperglycemia when the patient has come to an orthopedic emergency, because that carries the most adverse outcome in clinical practice. And this is extremely important because the moment somebody tells you, I'm not a diabetic, then this first diagnosis of hyperglycemia is rather taken lightly. And that's a blunder which you should never commit. Why are all these issues happening in an orthopedic emergency where we think that a patient of diabetes has come and we have to be extra cautious? Now, whenever you deal with a pre-surgical or surgical procedure, what you are looking at surgical stress, you ask your patient to go for fasting, pre-surgical fasting, starvation, anesthesia. When you combine all these three issues, what do they lead to? They lead to production of all the counter-regulatory hormones to insulin. We know that insulin is good. Insulin is required for glucose homeostasis to its normal state. But if you have excessive production of all the counter-regulatory hormones like growth hormone, ACTH, ADH, cortisol, glucagon, everything, then obviously it is going to increase the blood sugar pool. At the same time, because the patient is starving, so the other sources, the fat, the protein, and the production of glucose through other sources like gluconeogenesis and glycogenolysis will increase. On top of that, there is insulin resistance. The patient's food supply has gone down, and so is the insulin release. So if you put all these things together, what is going to happen? One single outcome, and that is a very high glucose pool into the system. And the moment you have high glucose pool into the system, it is likely to cause a lot of consequences. The most difficult one can be diabetic ketoacidosis, but on a day-to-day basis, impaired phagocytic function. And I was listening to a couple of the lectures before this oration where you talked about the increased risk of infection, and Dr. John was particularly pointing out it in the diabetic patients. So all these issues, reduced resistance to infection, delayed wound healing, and occasionally such patients, if left untreated, may end up with an acute myocardial infarction. So a hyperglycemic milieu is extremely dangerous for any orthopedic emergency to be tackled. While you must appreciate the importance of a hyperglycemic milieu, at the same time, you should always refrain to be overzealous in treating hyperglycemia, because hypoglycemia should always be kept in mind. And an attack of hypoglycemia in the emergency, about other things, it can lead to irreversible brain damage and also an acute myocardial infarction. So all these issues are extremely important, and you should be completely sensitized to this. Now, until a decade ago, there was a lot of emphasis on very tight control of blood glucose in emergency situations, particularly the surgical emergencies, the orthopedic emergencies. And it was a study by Vandenberg from Belgium who actually demonstrated that if you can achieve a blood sugar target of 70 to 110 milligrams per deciliter, that gives you the best outcome. And following that, there was a period of almost 1 decade where the diabetologists went overboard to treat their diabetic patients when they were called by the surgical colleagues or orthopedic colleagues. And they would say that, listen here, your blood sugar patient must be between 70 to 110 milligrams per deciliter. But then when the data was audited for next decade, it was found that that actually increased the risk of death and other complications. And then a global study was actually set up called the Nice Sugar study, which directly looked into the comparison of very strict control versus a slightly loose control. And when we talk about the strict control, it was 81 to 108 milligrams per deciliter, and slightly loose control was less than 180, and it was actually 140 to 180 milligrams per deciliter. And that clearly established, and now all the global guidelines clearly tell you that the best outcome to be expected in orthopedic emergency is when you keep the blood sugar between 140 to 180 milligrams per deciliter. Certainly more than 180 will have all the consequences of increased risk of infection, delayed healing, delayed, etc., all the things that I already talked about. And certainly we are not going to have anything less than 110. There are certain varieties of operations, particularly the cardiovascular operations, where you still have recommendation to have a little tighter control, and that is 110 to 140. But I think for the general purposes of any orthopedic procedure in hospital, 140 to 180 milligrams per deciliter should be the target. The next question is, on a practical basis, what do you do on the day of the surgery? Now, for patients of type 1 diabetes or patients of type 2 diabetes, the moment you talk about major surgery, you have to put the patient on a glucose potassium infusion. And if it is a minor procedure, basically you don't have to do anything. And in that context, when you talk about a minor surgery in an orthopedic thing, all that you need to do is that on the date of the particular procedure, you must stop any long, acting sulfonylurea. And then you admit the patient day before surgery, you conduct the surgery, you do it in the morning. Patient obviously on that day will not take the breakfast, and avoid giving any glucose because you have stopped the drug. So there is no point in giving glucose because the patient was fasting, and just monitor by finger sticks 2-hourly blood glucose, and the patient should be fine. The key is that you must have a good glycemic control, and the moment the patient starts eating, you restart with whatever drug, whether he was on metformin or DPP-4 inhibitor or sulfonylurea, whatever. This is very simple. But when it comes to another minor procedure, or it can be sometimes a major procedure, many a times a patient is returned to a physician or a diabetologist with an abscess or any infection where there is collection of pus, because the blood sugar is 350 milligrams per deciliter. Dear friends, with folded hands, I will tell you, please never ever do it. An abscess needs to be treated immediately. The release of the pus from the body will actually control the blood sugar. It will not increase the blood sugar. Yes, blood sugar has to be treated on its independent merit, but the abscess has to be drained. The pus material has to come out of the body. Otherwise, neither the blood sugar will be controlled nor the wound will heal. So this is an extremely important so-called minor procedure which needs to be treated like this. For a major surgery, obviously the patient has to be admitted at least 2 to 3 days before the operation, and the patient's blood sugar has to be stabilized by a basal bolus regimen 3 times with short-acting insulin and maybe 1 shot of long-acting insulin. And on the date of operation, diabetic patients should be given the priority to be operated first thing in the morning, and the GPI, glucose potassium infusion, should be started. Patient obviously will be fasting, no insulin from the usual source. GPI infusion is started, so the usual dose of insulin does not need to be given. And once again, you monitor the blood glucose 2 hours. You can increase the monitoring frequency from 2 hours to 1 hour to 30 minutes, depending upon how volatile this situation is. Once the patient's blood sugar is controlled, patient has started eating, then you need to transfer from the GPI infusion to subcutaneous insulin administration. And I'll come to that in a minute. The most important thing that I would like to tell you, that if you are using a sliding scale, the rightful place of sliding scale is in the river Ganges. No person should ever use a sliding scale in clinical practice. This is the most unscientific procedure to give insulin in an emergency situation or in a hospital setup. You may ask me why. The answers are many-fold. There are not one, there are at least 15 problems with this sliding scale. Sliding scale is basically a reactionary approach to treat blood glucose. The blood sugar is high, you give more insulin, blood sugar is low, you give less insulin, and you keep on doing this yo-yo phenomenon with your patient, and the patient's blood sugar never gets to the target. And therefore, please don't use sliding scale. Then you will ask me, if I don't use a sliding scale, then what do I use? You have to use a glucose potassium infusion. This is one option, but I will come to a more simpler option. And many people think that GKI infusion is a very, very difficult thing. I can tell you this is the simplest of all things. All that you need to do is to take a 500 ml bottle of 10% dextrose, add 15 units of insulin and 10 millimoles of potassium. What is the big deal in this? And you start the infusion, and then you have to adjust. Now you can tell me 2 different scenarios. Now look here. This is one scenario. You have started with a GKI infusion. The blood sugar was high. You increase the insulin. So what you did? Patient went into hypoglycemia. So again, even you are giving a GKI infusion, you are increasing the risk of that yo-yo phenomenon. So please don't do it. There is another situation where you have started with this 15 units in one bottle of 5%, 10% dextrose, and the blood sugar came here, but you are still not happy. So then what you did, you had another bottle in which rather than 15 units, you had 20 units. But that will give you a very smooth reduction of the blood sugar into the normal zone. So rather than increasing the dose of insulin, you have to use a different bottle where rather than 15 units, you have 20 units. This is such a simple thing to do to take care of any major surgery in orthopedics. And this is the way we do it. This is the infusion bottle, this is the insulin syringe pump, and this is how the cannula goes into the vein of the patient, and that is how it is used. If you do not want to use this, even a more simpler version is the IV insulin infusion pump. I'm amazed. I have been to many hospitals. More than 75% of the hospitals do not have this IV insulin infusion pump. And when I ask the administrators, why don't you have this pump? They say, oh, it must be very expensive. Have you ever tried to know what is the cost of this? This costs 15,000 rupees.
20,000 rupees. Even the best variety in the market costs only 70,000 rupees. So why can't every hospital, every clinic have an IV insulin infusion pump? And then how simple it becomes. You take this 50cc syringe, 50 units of insulin and 50 units of normal saline, you put it and press the button. 3 units per hour, 5 units per hour, 6 units per hour. And because it is intravenous, so there is no question of a yo-yo phenomenon. Because when you give subcutaneous insulin by the sliding scale, do you know the pharmacokinetics of insulin? Even if you give a rapid acting insulin analog, it takes 30 to 45 minutes to start. It peaks at 4 to 5 hours and then it clears over a period of 6 to 8 hours. So when you are giving a subcutaneous insulin by using a sliding scale, you are completely creating a chaotic situation. But if you are giving intravenous, you are giving 3 units per hour after 1 hour or 2 hours, whatever your frequency of assessment is, and then you find that, okay, we are still not on the target. So only that you need to increase from 3 units per hour to 4 units per hour. But there is a consistent, there is no question of a peak and trough situations with insulin concentration, and therefore it will never lead to glycemic lability, which is completely undesirable. So I think if one message can go through today, that every hospital, every clinic should have an IV insulin infusion pump, I think this operation will be successful. Once you have completed the surgical procedure, then things are very simple. Continue the IV insulin either through the GPI infusion or through the insulin infusion pump. And once the patient starts eating, all that you need to do is to stop the IV infusion of insulin and bring the patient back to subcutaneous administration. How much? Then people think, oh my God, this is a very complicated thing. I'm not going to do it. This is the simplest thing of all. Just look at your chart that in last 24 hours, how much insulin did you give? If it was 50 units in 24 hours, so the requirement is 50 units. So 50% of that should be given by a basal insulin and the remaining 50% by 3 doses of a prandial insulin. So 50-50, 60-40, whatever distribution you want to be, that is your choice. Or you can take help of your colleague. So this is a simple way to transfer patients from IV insulin infusion to subcutaneous insulin. And you have very simple protocols which are available on the net, which are available in the book. One of these, which is very favorite to me, is the Portland protocol. This is the one in patients of type 2 diabetes, what you see here. And we don't need a lot of insulin, I can tell you. 3 units per hour, 2 units per hour is good enough in patients with type 2 diabetes. And 99% of our patients are type 2 diabetes. Only 1% of our patients are type 1 diabetes. So I think this is the insulin protocol. Hardly 1 to 2 or 3 units per hour is required for maintaining euglycemia. And when I say euglycemia in orthopedic emergency or in orthopedic surgical procedures, I mean 140 to 180 milligrams per deciliter. So ladies and gentlemen, I would like to conclude by telling you that management of diabetes in hospital, in orthopedic emergency, etc., is not a very complicated issue. It is perceived to be very complicated. But if we apply ourselves with the scientific facts and using these simple gadgets, I'm sure we will be doing a great service to our patient and we will be having a wonderful outcome. Amulya had added in my caption of talk for improving outcome. Thank you very much, and thank you very much for giving this honor to me to deliver the first Dr. Vijay Narayan Singh Memorial Oration. Thank you very much.
This was an extraordinary talk. We got so much information how to manage a patient, orthopedic patient with insulin or diabetic problem. Sir, thank you, sir, and congratulations. Congratulations.
So this session is closed.
May I request Dr. Vikram Bedi to please come and moderate the next session?
Now, the new session related to orthopedic oncology session in nutshell. And I would like to invite now the next session is on orthopedic oncology in a nutshell. Now, I would like to invite Dr. Captain Dilip Sinha sir as chairperson. Sir, please. Now, Dr. Maruti Nandan sir. Sir, Dr. V.K. Thakur sir, please. Please, sir, come on there, sir. Yes, sir. I'm handing over to Dr. Uli. Good afternoon, everyone. At the outset, I want to thank Amulya sir and the team GOFCON for giving me this opportunity. So today, this is a very interesting topic on orthopedic oncology. And we know that bone tumors or the sarcomas, they constitute only 1% of all the tumors. So our exposure to these tumors are very rare. Very rarely we are trained to handle these tumors during our practice, clinical practice, as well as during our residency training. So one factor, one conversation which I always have with my colleagues and friends, that whenever they see a bone cancer case, they always say that the prognosis is not going to be good. And the other option they always say is better to amputate the limb than to go for native limb salvage. But I want to change this perception, and probably this platform gives us an opportunity to showcase what new has come up, what are the recent advances because of which we are going more and more aggressively in the treatment of this bone cancer. So first perception that the survival outcomes are poor is no more correct. That was in the pre-chemo era when, in spite of doing radical surgeries like amputation, the survival used to be only 20%. But as the chemotherapy evolved, we are now talking about survival outcomes or the cure rate, you can say, somewhere 60 to 80%, depending in a non-metastatic scenario. Even if it is metastatic, the outcomes are not bad if we can do the metastatectomy, and we have all the modalities, surgical instruments to do that. The other phenomena that people always say that whether you do limb salvage surgery or amputation, the limb salvage has higher risk of recurrence. But the literature has shown repeatedly that if it is done with proper principles, the rate of local recurrence are no greater than doing an amputation. So in my practice, mostly what we do is more than 90% of the cases they undergo a limb salvage surgery. So what are the factors that has actually improved the outcomes? It is not just the surgery. In fact, it is the multimodality approach that we are using nowadays, especially related to chemotherapy, which has changed dramatically the outcomes. And now we are moving more and more into the depth of understanding the disease biology. Right from chemotherapy, we have immunotherapy and more targeted approach where we can pinpoint and hit the right targets. Then we have other adjuvant modalities like radiation therapy. Where our surgery is not feasible or it is a marginal type of resections, we can improve the outcomes, not only with local recurrence, but also in terms of survival outcomes. Then the prosthesis, the availability, the affordability of implants has dramatically come down. The implants which used to cost 8-9 lakhs, now with NPPA guidelines are available within 1.2 lakhs. So all these factors have improved our outcomes. So I'm not going much into the detail of benign disease, but just want to say that there are many tumors like simple bone cysts and aneurysmal bone cysts, which traditionally were operated with open procedures. And nowadays we can do percutaneous treatment with just single incision, do sclerotherapy or radiofrequency ablation. Like in this case with a young boy who had a lesion, you can see that in the ischial fibrosity, there's a lesion there. And so this is the classical picture of multiple fluid levels. And in this case, biopsy tube and aneurysmal bone cyst, where we used sclerosant agent, and this led to the healing with a single shot injection. Previously, such treatment required probably excision of the bone or extended curettage. Coming to the more aggressive type of lesions, what we call simply as sarcomas, or in layman term as bone cancer. The buzzword nowadays is the limb salvage surgery. So like I said, now it is possible to do limb salvage in more than 90% of our cases. The three important steps. The most important is to remove the tumor with a wide margin. That is the crux. If it is not removed properly, then whatever we do, whatever type of reconstruction, it is bound to fail. Patient may have local or systemic recurrences. So that a lot of evolution has come in the way we approach the tumors, the way we dissect them, and we reconstruct them. These are some types of the resection that we do in bone cancer. I'll just show you with some of the examples. Like this was osteosarcoma of the distal femur. Osteoarticular resection means where we cut it through the joint, like here. And this is one of the most common, in fact, because most of these tumors are epimetaphyseal locations. So we operate this where we have implants, and patients from the next day can start bearing weight. They can do all their regular activities. Coming to the other type of lesions, like in this young girl, there was a lesion in the distal tibia. You can see a pigmented zone, which was diagnosed as Ewing sarcoma. It was not involving the joint. So when the disease is diaphyseal, in those situations, we can resect the tumor with a wide margin, but the challenge is now how do we reconstruct them? So there are different options. I'll just go through some of the examples. This is something new. I would not say new, it has been there for almost 2 decades, but it's still not available everywhere. So here we remove the tumor with wide margins on either side. You can see that the bone is excised out, and then we send it for radiation therapy. So this is done intraoperatively while the patient is on table. We take the bone out, send it down to the radiation department, and they radiate with a high dose radiation. We bring the bone and put it back. So this is called sterilization of the cancerous bone and reimplantation. So there are different methods of sterilization of the cancer cells. One way was extracorporeal radiotherapy. The other, I would show you, this is another example. And in fact, this case was done in Mahavir Cancer Sansthan, where I visit for my monthly cases. So this girl, young girl, had periosteal sarcoma in the distal tibia. Similarly, we do not have good results with prosthesis. So here, rather than taking this bone completely out, there is a new modality where we can sterilize the cancer cells while it is still inside the body. And this is done with liquid nitrogen, and it is called pedicle sterilization. So you can see here, we dissect the tumor out with wide margins. We cut the bone, we take it out of the body in a completely separate table. And this is the liquid nitrogen, which has a boiling temperature of minus 190 degrees centigrade. So this cryo-frees all the cancer cells and everything. Then this bone is reimplanted. And this is her functional outcomes. I saw her almost a year, after a year, and she has very good function. The other video was of her jumping here and there. So these are the functional outcomes where we can sterilize the bone while still inside the body. Sometimes when the disease involves the entire bone, we can do total bone replacements. Like in this case, this young boy had a total femur done. These cases we can do in humerus, where we can replace complete humerus, complete femur, which is also quite often done rather than going for other option like a hip disarticulation. These are, nowadays we have all these modular prostheses where we can assemble exactly to the size of the implant, which are very stable. And you can see intraoperatively, we check the stability. And these are constraint type of processes, mostly at the knee joint. And you can see this is this is the modularity where exactly you can replicate the same length of bone what you resect out. This is the follow-up. All these patients with prosthesis, we start mobilizing them from the day one. And this is almost a year after follow-up that when this young boy is an independent ambulator. But the challenge lies in pediatric population because they have small bone size, they lose the growth potential once the tumor is excised, like in this young girl who was 8-year-old with pathological fracture of osteosarcoma. Nowadays, we have Indian-made implants which can be used to achieve limb salvage, and like this was done. You can see at follow-up, she had some shortening, so we did percutaneous expansion, and this is her follow-up, which she had sent the video from where she was. So the take-home message is that amputation is no more the surgery of choice in sarcomas. We can achieve limb salvage in more than 90% of the cases. We must be aware of all the armamentarium we have to achieve limb salvage. It is no more a costly affair. We can use biological modalities like we are commonly using liquid nitrogen or something. And ultimately, it's the multimodality approach which improves the outcome. Thank you.
Good afternoon, everyone. Good afternoon, respected chairpersons. I thank all of them for giving me a chance to speak on this podium. Today, I'm presenting a paper on long-term follow-up of giant cell tumors, which were treated at our institute in PGIMS Rohtak by Dr. Dilasi Kundu, and I was the assistant during the follow-up. The giant cell tumors of bone are locally aggressive tumors with limited metastasis. They account for around 4 to 5% of all the primary bone tumors. 20%, they make up the 20% of all the benign tumors. The peak incidence of age is 20 to 45 years of age. They usually occur in the long bones and in the end of the long bones. The most common site being the distal femur and the proximal tibia. Clinically, most of the patients present with bone pain, but the overall clinical course of the giant cell tumor is dependent on the local recurrence of the tumor. Depending on the type of treatment, depending on the type of the place where the tumor is present, the treatment may vary from complete excision of the bone to extended curettage. The surgical resection of the is the universal standard for the treatment of giant cell tumors, as most giant cell tumors are benign and are located near the joints. So there is a way of shifting from intralesional curettage, from excision to the intralesional curettage, as the excision causes very high functional limitation. But since in the cases of extended curettage, there have been high recurrence rates found. So we have to maintain a balance between the excision and extended curettage. The intralesional curettage may be combined with PMMA, void filling, hydrogen peroxide, phenol, cryotherapy, and as these modalities reduce the recurrence of the tumor. The treatment of primary GCTs is done by extended curettage, which involves the curettage with high-speed burn, and we also use electrocautery to burn the cavity in the spray mode. We can use liquid nitrogen, we can use phenol, we can use hydrogen peroxide. The aggressive giant cell tumors, which can be Campanati grade 3, may need complete excision of the tumor. Various studies suggest that the survival rate of
even in the metastatic tumors, metastatic giant cell tumors, the survival rate can be 84 to 100%. The diagram, the figure shows the procedure of extended curettage, and we are showing burning of the cavity with electrocautery spray mode. This is bone cementing done. This is the excision of proximal humerus specimen and excision of distal radius. In our study, there were a total of 83 patients of giant cell tumors that were operated in the last 10 years with a minimum follow-up of 2 years. The patients were called telephonically and were examined clinically and radiologically. The overall range of motion and the X-ray of the chest to determine the pulmonary mets was done. And additionally, the details of the previous surgery were also taken. The recurrence rates were noted in the patients operated with excision and extended curettage respectively. The functional outcome of the patient was assessed by MSTS score, and the quality of life was assessed by SF36, short form 36 score. This is the MSTS scoring. The results, the mean age of the patients in our study was 32 years for males and 31.8 for females. In females, the overall rate, overall incidence of giant cell tumor was high. Tibia came out to be the most common site for the giant cell tumor in our study, followed by distal femur. 53% of the patients diagnosed with GCT were treated with extended curettage, and 47% were treated with excision of the tumor. This is a graph showing the frequency of the giant cell tumor in different bones in our study. The most common complications of giant cell tumor include fracture, infection, pulmonary metastasis. In our study, out of 83 of the patients, only 7.2% of the patients reported with complications. The infection was reported in 4 patients, that is 4.8% of the total patients treated with excision. 1 patient was diagnosed with common coronary nerve palsy, and 1 patient was with infection and fracture both, and without the evidence of any recurrence. None of the patients reported with pulmonary metastasis. This is the graph showing complications in our study. In our study, the patients treated with extended curettage had good functional outcome with mean MSTS score of 25.7, while in the cases of excision, the average MSTS score was comparatively lower. That is significantly, statistically significant. On comparing the quality of life in both the groups, the mean SF36 score was 84.89 in group of excision, while that in case of extended curettage was 91.8. That is statistically highly significant. Recurrence rate was observed to be higher in extended curettage group, and excision was in excision the recurrence rate was lower. Conclusions from the observation of our study, we find that this retrospective study shows that in the cases of extended curettage, the functional outcome and quality of life is better in comparison to the quality of life in the excision group. While the recurrence rate in extended curettage group is higher, that is 9%, and in excision group it is only 6%, 5.1%. So we can say that if we maintain a good extended curettage while operating, we can reduce the recurrence rate in extended curettage group as we have done in our study. Thank you. These are the recurrences in our follow-up. At 61 months of the follow-up, and at 24 months of the follow-up.
Thank you, Dr. Karnish. And now we move on to the panel discussion related to orthopedic oncology session. So, may I invite our panelists, Dr. Manisha Singh, medical oncologist. Can we have some chairs? Dr. Neeta Tridevi, radiation oncologist at Mahavir. Dr. Pallavi Agarwal, pathologist at AIMS. Dr. Kumar Rahul, radiologist. Dr. Rajesh Goswami, surgical oncologist. And our own John Mukhopadhyay sir, please, orthopedic surgeon. And two of our panelists had to leave because they had to catch a flight. So I think without much delay, we should start. So we have a esteemed panel, and so we start with the case presentations now. So this is the first case where a young boy had pain in the thigh for 4 months, and I think you can see the screen. Yeah. So we can see that this is the X-ray. So we have our radiologist, Dr. Kumar. Okay, you can see in front of you, sir. Here. So what is your comment looking at the X-ray? What does it look like? Right.
And most important thing which we should focus on this X-ray is that the lesion is permeative with the zone of demarcation,
okay,
which is very wide. Permeation. Okay.
Right.
This suggests more of an aggressive kind of lesion. It can be either osteomyelitis or sarcoma, depending.
Right. So, John sir, if such a lesion presents to you, you are in your OPD and a patient has come and he has an X-ray like this. So, what would be your approach to our young orthopedic sitting here? So, what should they do now?
So I think this is a lesion where if you see this, you should, it should immediately be a red herring for, I mean, it should be a warning sign for you to investigate it further.
Right, sir.
And you would do the sequence of events would be to make sure you do something like get an MRI, get a CT chest, and also maybe a bone scan to look for any other lesions elsewhere, because and then proceed to a biopsy before you do anything for this.
Right, sir. So like Dr. Rahul described, this looks something like a aggressive type of lesion with permeative type of destruction, wide zone of transition, which should raise the suspicion of some red flag. This is not something which is routine. So if we have residents, can we have just hands-on? What would you like to do if a patient start on first with the antibiotics, or we should do a biopsy upfront or MRI? Who goes for the first option? Anybody? MRI. Okay. So we have a good trained people here, but unfortunately, this patient was just treated with antibiotics for 3 to 4 weeks and sustained a pathological fracture. Now he has come to your emergency department. So what should be done? Sorry. So if a patient has come to the emergency with a pathological fracture, what should be done? Should it be internally fixed? And if so, whether we should use nail or plate, or you want to do a biopsy, or we fix it and send the sample for biopsy. Any opinions from the crowd, from our esteemed guests? Okay. So, Vinita ma'am, so you are here. So if such a patient comes to in an onco setup with a fracture. So what do you advise them? Should they meet the orthopedic surgeon or we should evaluate further?
Basically, any patient who is presenting to us with a pathological fracture, before we act or before we think about the management, it's important to properly think. We should properly diagnose the case. We should properly stage the disease, and then we should embark on the management part. So this is the dictum which should be followed.
Very precisely told that for any pathological fracture, before any intervention is done, we have to diagnose it. So there is a protocol. We will go into that, like similarly what Dr. Vinita said, first diagnose, then stage, and then come to the treatment part. Don't directly jump to the treatment part, which was done somewhere here, where wherever he presented, he underwent a retrograde femur nailing done. And the sample was sent intraoperatively while doing the nailing. That whatever comes, let us see whether it is benign or malignant, then we will act accordingly. So, Rajesh sir, you are here. So what is your option? Like if a case is done like this, patient has presented with a pathological fracture, whether is it the right thing to do? Because there is a fracture, we have to do the nailing or plating.
This is absolutely incorrect treatment. Whenever we diagnose or we suspect to be a pathological fracture or malignant disease, as rightly said by you and others, that we should do the staging first and correct diagnosis. Biopsy should have been done in this case before anything be done. And this is to differentiate here also that pathological fracture comes into two setups, whether it is a primary bone tumor or whether it is secondary bone tumor, metastatic scenario. So the management part is entirely different in metastatic bone disease and primary bone disease. In this, biopsy should have been done first, and then only the other treatment, most probably because in neoadjuvant chemotherapy should have been given, and in this patient, I think limb salvage would have been possible.
Right. So he presented to me at this stage when already somebody distal femur nailing was done. You can see the contamination. The entry point was through the patella ligament. This was the contaminated part and another screw proximally. So if in a pathological lesion like sarcoma, somebody has put a nail, rod or plated it, it leads to all contamination. So in such a situation, we have no other option. And you know, this, you can see here, the disease it comes back in a very fulminant way. And the concept, like I had presented in my previous talk, we have to exercise with wide margins. Wide margins means tumor should be completely out. Not even microscopic residue should be left behind. So in this case, to achieve wide margin, he had to undergo an amputation, which in other scenario, if biopsy was done, we would have got the diagnosis, we would have started on treatment, we could have easily done a limb salvage surgery. So, yes, I want to ask Manisha. So, in this case, I had to plan for, this was osteosarcoma contaminated, I had done amputation. We know that osteosarcoma requires chemotherapy, but when we are doing amputation, do we need to give chemotherapy still?
Well, the message for all the PG students sitting here, osteosarcomas or any bone tumors are systemic disease at presentation. We have to understand that. We have to keep our eyes wide open that something which looks local can never be local. Day one, when we talked about biopsy, we have the latest data that if you put an incorrect biopsy scar, that can lead to 25% of the cases you have to alter your treatment plan. So just imagine out of 125 patients we have to alter, we cannot do a limb salvage because it did an improper biopsy scar you have put in. Secondly, some other investigations as well. If you have done a serum LDH, these are the basic investigations the PGs should know. If it is said that the serum LDH is towards a higher level, in fact, in a local disease, which is supposed to be local, the patient has 80 to 35% chances higher prone to have a metastatic disease. Your serum ALP level, these should be done at the baseline when the patient has come to you. Now, talking about chemotherapy, we know that Today, the osteosarcomas are such a good to behave that 90% of the patient can be salvaged by having a limb salvage, provided you have approached in a proper way. And if you have contaminated it, you cannot do a limb salvage. In this case, you have led to a drastic thing, what we call amputation. But even if you have done an amputation and you have not managed it properly, within days or months, the patient will have foci in the lung, the patient will be labeled stage 4 and will be losing the life of the patient. So that is the reason pre-surgery, we start with neoadjuvant chemotherapy to check for the micrometastasis, to hold the control of the disease, and then only you put a knife into that, so that you cannot, dare to have the spills, and this sort of is really contented.
So he was lucky that he was non-metastatic and he was on chemotherapy, and so far he is non-metastatic. Yes, sir, please.
The mic is safe.
You said that the nailing was done.
Yes.
In this case. And you have done the disarticulation.
Yes.
How you assured that you are going to get a reticle bond, number one. Number two, you went out for disarticulation in this case. As madam has mentioned that it is a systemic disease.
Yes.
Did you give a chemotherapy before going to this disarticulation?
So the way we approach such lesions are, first, like we said, we have to diagnose, like biopsy was already there. Second, staging, and I would just go through this slide. So this is the SOP, the standard operating protocol, how we should approach a bone lesion. And the diagnosis is based on our clinical radiological impression, which has to be confirmed with a biopsy. We have to stage, which can be done with a CT thorax and bone scan if PET is not available. Otherwise, PET is a single modality to diagnose. Third, the management part. So in this case, since it was a retrograde and the margins are planned based on the MRI and CT scan. Yes, so this requires a modification of the flap. This is not with the yes. So this requires a modification of flap.
That's what I wanted to convey. You know, if you want to get a margins which are wide margins, so you have to be very sure. You have to see your MRIs properly, which soft tissue is going in. Then I think it is a fair chance with this patient where you have not been treated properly to give a neoadjuvant chemotherapy, systemic therapy, and then go hybrid.
So even to add upon, even in a metastatic tumor, when we have to do a amputation on a palliative setup, then also we prefer to go with a neoadjuvant and then we do a amputation. So this is, depending upon the situation, even in metastatic lung mets also, I prefer to go chemo and then I go for a palliative amputation.
So there is also a very common discussion, which I see in WhatsApp groups, when the patient has very lytic lesion, which resembles like a GCT, and always it is said that we will operate first and we will send the biopsy. So please remember that this is also not the correct thing to do, because we read books, how the tumor looks like. Tumor don't read books. So they may present in multivariant way. So they may be radiological mimickers. So considering that, the another discussion part which always comes out. So intraoperatively, if we send the biopsy and then do the surgery. So we have Dr. Pallavi. So Dr. Pallavi, I want to ask you, so for bone tumors, if we are planning a definitive surgery, so somewhere, how confident you are in giving a report intraoperative that it is a benign condition or malignant condition if we send the biopsy?
Like intraoperative frozen sections have its own limitations. While reporting it, we face a lot of problems in reporting intraoperative. First of all, the sample might be inadequate and not representative from the area from where we want to sample it. Plus the bony trabecules, which is sampled during the procedure, they need decalcification normally, which is not possible on cryostat per se on that on-table decision. Furthermore, this sudden freezing of the tissue leads to they just distort the morphology of the cells. It becomes very difficult sometimes to report on such a small tissue with distorted morphology. And furthermore, loss of antigen, loss of DNA structure, many things occur on sudden cryo freezing of those tissues. So per se, cryostat or frozen sections are very important for margination. Like we can say that margins are positive or negative, but for diagnosis, it has its own limitations.
For a definitive diagnosis, we should have biopsy first. So this message should be very clear with all of us. So what should have?
So I think this is important because We actually had a problem some time ago, where in a child where everything was reported as infection. But I was still a bit suspicious, so I said, let's get a frozen section and then do. And the frozen section said it's infection. And then later on, the same pathologist reported it as malignant. It was a Ewing's tumor. So that's something you really have to be careful of. The frozen section is not a confirmative biopsy.
It's not, yes. So biopsy should always be done prior to a definitive procedure. So looking at the X-ray, the protocols that we should follow. So similar situation, first splint the patient, complete the workup, get the X-ray and the MRI done, which would have confirmed us after biopsy that it is osteosarcoma. Then we could have done a bone scan and the CT thorax. And then the treatment in this case would have been doing a limb salvage surgery. And that required a wide excision of the distal femur, which in this case had to be turned into a hip disarticulation. So like John sir in his first part, like he had explained that whenever we see a pathological lesion, the most common differential that comes to our mind is either it is an infection or a neoplastic etiology. While neoplastic, it may be either benign or malignant. And why it is important that we follow this SOPs? Because the treatment spectrum varies, right from observation for simple lesions like exostosis or osteoma, to extended curettage, like in lesions like ABC or GCT, to wide excision for more aggressive tumors. But once it comes to sarcomas, we have to get excision with wide margins. There is no shortcut for that. And second, we need to give the multimodality approach with, depending upon the histology, if it is sarcoma, we have to start on chemotherapy followed by surgery. So the take home message is that we should have a high index of clinical suspicion in any pathological lesion. Pathological fractures, treatment is not emergency. Diagnose it, stage it, and then treat it. John sir, I want to ask you, whenever there is a lesion, do you always send it for biopsy and culture also? Or
yeah, so
like
we have a saying, always biopsy a culture and culture a biopsy.
Yes, sir.
So whenever you're planning to do a culture, also send a biopsy. And if you're planning to do a biopsy, also send a culture.
Right, sir.
One more point I just want to add that before we move to the next case, biopsy, we are laying a lot of stress on biopsy. Pre-operative biopsy should be must before we approach for any treatment. But biopsy, I have seen a lot of cases, FNA has been done and also proper biopsy in the form of either open or core needle biopsy. I think this is the only two biopsy technique which should be advocated and which should be preferred so that we get adequate sample not only to diagnose the disease, but also to get some IHC and cytogenetic information also. So this is really important.
So
very valid point.
Fine needle aspiration cytology is okay for thyroid tumors and things like that, but not for bone tumors.
So last point also from my side, because from the medical oncologist side, because this is the advancement in osteosarcomas, and we should know that the biopsy specimen is not only to diagnose it as a level biopsy, because what she said that cytogenetics and molecular testing also has to be done on the biopsy sample, because once you have labeled the disease as metastatic and we think that we can do nothing, but today we can do something because we test for the TMB, that is the total mutation burden. And if it is more than 10 megabase per tumor mutation, we have drugs like immunotherapies also, which are working for osteosarcoma. So this is all something new that we talk about, immunotherapies, targeted therapies, in a case which is a metastatic osteosarcomas. So small chunk of the biopsy will not suffice. We'll have to have a proper tissue so that in due course of the time, even if it's a localized disease, it has progressed to metastatic disease, or the patient is metastatic at presentation, we have adequate information regarding how to proceed this case further.
Yes. So if we just summarize the crux, if you have a patient, please don't ask patient with a light lesion or a bone lesion, please don't ask for FNAC, get a proper core biopsy done. And it does not require open surgery. You can do it just with a Jamshedi needle. And I'll just show you how we can do in this case. So Dr. Rahul, again, this is a young man who has presented with a
yes, sir. Case. Why did somebody do the nail?
So I think that person that's happening. That's why we create awareness about this, that this practice should be abandoned.
Radiologists sitting here and first go, including the orthopedic surgeons, we also feel the same way. It's malignant. अछूत है.
Yes, sir.
नहीं छुइए implant मत डालिए. Making a DFN, pushing the malignant through all the way
to the compartment.
As I said, cutting it,
inviting muscles also to be the part of its transmission, and then doing all those things. Second thing, man, I said immunotherapy is a viable answer nowadays. Was something done for the immunotherapy in this case?
So this case required chemotherapy only. This was not a case where immunotherapy was advised.
So immunotherapy is a very costly affair. One vial costs 1 lakh. I'm also giving to my patients. My patients are immunotherapies, and most of them they are covered patient, where they are somebody or else is paying from own pocket, and there is no limitation to immunotherapy that 3, 4, or 5 or 6 cycles. You have to continue immunotherapies for long. The only message was we have something, not only chemotherapy, but beyond that, to have so that we can prolong the patient's life.
And the first
Something we have.
line of management is chemotherapy. So
Upfront is chemotherapy. Failing to chemotherapy, we have to add immuno. Immuno till date is not upfront. We have to add immuno once the patient has progressed on chemotherapy.
So Dr. Rahul, you can quickly enlighten us. What do we see here?
This is X-ray knee showing osteolytic lesion in the subarticular location of the distal femur.
That's important, subarticular lesion.
Cortical margin is thinned out, and when we compare with the previous case, the zonal transition is very narrow. That is very important to look at, because
So which means we can demarcate, we can make a line where it is. Yes.
With a narrow zonal transition. That suggests that there is more of a benign kind of lesion rather than a
Right.
kind of.
Right. So what is your radiological
And
impression?
considering the age, before coming to any diagnosis on an X-ray plate, we should look at the age of the patient, because it's when it is 20-year-old male.
So it's a young man. Yes.
Young man, so more likely the primary diagnosis is GCT.
Post maturity. So that is one differential that we have. What else would you need to confirm your diagnosis? What do you need any further investigation, or
we should go for an MRI in this case?
Right, MRI. So this is very important that whenever we have a pathological lesion, before we proceed for further biopsy or anything, we must characterize what type of lesion it is. And just I continue with you, what additional information MRI will give to us?
A few things. What is the status of the lesion? Whether there is any split lesion or not.
So there is MRI, yes.
The lesion is again now a well-defined lesion. The soft tissue component is not that big. There is no permeation of the lesion is seen. So this again suggests that the lesion is a benign lesion. There's no aggressive. This is not that aggressive. What we can say based on this MRI.
Right. So Rajesh sir, though our radiologist said this looks like GCD, would you still like to do a biopsy?
Yes, of course. In this case also, we should go for biopsy first and then only.
Yes, like I said, we read books that these are the characteristics, but the tumors, these are called radiological mimickers. You can have ABC presentation like this, you can have clear cell chondroma presentation like this, you can have osteosarcoma presentation like this. And all the histological subtypes which I have said, everything has different modality of treatment. Probably for a ABC, you can just do a percutaneous sclerotherapy. For a clear cell chondrosarcoma, just wide excision is sufficient. And if it is osteosarcoma, this requires chemotherapy followed by surgery. And if it is a GCT, it requires extended curettage. So the discussion was going on, FNSE was done, which showed giant cell rich lesion. So, ma'am, are you happy with the diagnosis, Dr. Pallavi? If it shows giant cell rich lesion, should we jump onto it and start the treatment?
Giant cell rich lesion is a vague diagnosis. Whatever
Yes.
cells we get in the cytology, we just report it as giant cells are seen, or they are admixed with some malignant cells or benign cells. This doesn't make a definitive diagnosis. We should definitely go for biopsy and not go for this. This is just a finding in that lesion.
Right. So this is very important that we should always have a biopsy, because giant cell rich lesion can even be present in giant cell rich osteosarcoma. You may have other variants of sarcomas which may have giant cell. So we have to read properly. Is it a giant cell tumor of bone or just a giant cell rich lesion? It has to be clearly categorized. And if not, we have to ask our pathologist. Oh, very important information. Whenever we send the sample to our pathologist, I don't know how is the system here, but usually when I send the reports of our MRI, X-ray, my own clinical impression, what is there, and then we send. Do you get such reports?
Yeah, definitely. Without radiology, we don't report biopsies. It is must.
So that should be the standard practice.
Yeah.
So when do we need FNAC? Is there any role of FNAC? Johnson said like some cancers like thyroid and other, we may have FNAC. But in case there is already a diagnosed case and now you see other lesions at other sites, you just need to know whether it is malignant or not. FNAC may be sufficient, or in a known case of sarcoma with subsequent recurrences, FNAC may be used. Rajesh sir, would you like to comment more about the biopsy technique nowadays, what we do?
Yes, it's very important to know the biopsy technique, particularly in bones, because it's a hard part of the body. And many a times, core needle biopsy cannot be done in the bone thing. So there is a J needle biopsy. This is invention of our country. This is Jamshedi needle made of steel, and it is first started in Tata Memorial Hospital, Mumbai, and then I don't know whether the PGs are aware of this needle or not, because it makes the biopsy technique very, very simple, and open biopsy should be avoided at all costs, because in further surgery it creates a lot of problem. So open biopsy should be avoided, and jade needle biopsy should be done in all cases.
Well, you have very rightly said, and we always read in books why biopsy should be done by the team who is going to operate the final surgery, the definitive surgery. Because the approach in orthopedic oncology, when suppose if it is a lesion in the medial condyle, we have to go through the medial aspect, dissect out the vessels, protect the nerve, and then remove everything. So when I plan a biopsy or anything, I do not think in terms of biopsy. I plan my final surgery. If it comes out sarcoma, what I'm going to do? If it comes out a benign tumor, what I'm going to do? What is going to be my incision? And I mark my incision, and on that incision, I place my needle so that this biopsy tract is also removed finally. So finally, it was good. It came out as giant cell tumor of the bone only.
One thing I wanted to add is, in this biopsy, we should go for image guidance always, so that we can hit the right area, not sclerotic or non-viable areas. We should hit the viable areas for proper diagnosis.
Another very important point, like what Dr. Pallive highlighted, if there is a bone tumor and it has a soft tissue component also. So doing a biopsy from soft tissue component will yield the same result what it will do from the bone. You have to take the representative tissue. Many a times you may get the results, tissue is not adequate. So I'm sure Dr. Pallive would agree that she does not require a half kg of tumor to give the diagnosis. But what she meant is that she requires representative tissue. So complete radiological imaging workup is done so that we know where to biopsy, which is the representative site. It should not be a necrotic part, not the cystic part. It should be from the solid areas so that we get the right diagnosis. So John sir, if there is a lesion like this, so GCT has come in the distal femur. So how would you plan for this surgery?
So I think in this case, although there's breach of cortex, you still have enough bone there, and the articular, the joint is actually not involved.
Yes,
sir. Gone very close to the cartilage, but the joint is not involved. So I think here, what you would do is an extended curettage. The importance of extended curettage is that you use high-speed burrs. I think this is very important, that apart from your standard curettage procedure today, when you use a high-speed burr, it makes a huge difference.
Yes, sir.
If you do it yourself, you'll realize however much you curettage, and then you use the burr, you see little crevices and things coming up. The second thing is use an adequate window, because don't try to do this through a small window, because then you will not reach all the area. And then question of adjuvants is something which, if you use a high speed burr, how necessary is it? I don't know. Maybe you don't need to do things like going to etc.
So I think a few important points that John sir said. Sorry, I interrupted you. So you.
Sorry.
Yes. So very important that if there is a lesion, what you see here, if it is coming up to 7 or 8 centimeters, your window should be up to the lesion maximum longitudinal extent. You have to open that so that you have full access all around and you can get a good curettage. So once we have made the window, you do gross curettage with curettes, screws. Then we have to use a high-speed burr. I operate with many orthopedic teams, and sometimes they give me this drill machine with 1,000, 1,500 RPM to use as a high speed. But that is not the high speed burring. you need to have at least 30 to 40,000. Usually we operate with the machine electronic ones which have up to 60 to 70,000 RPM, which is really required to get adequate clearance and extend our margin. The routine ones usually nowadays, if you don't have, still you can use the micromotor bursts which are available, especially in the neurosurgery or the dental or ENT department. So that is very important. Other points that we will go one by one. So coming to the point, like what is extended curettage? This is the word which we always read in our books. So extended curettage is something what we use to further increase our margin of interlesional curettage. Once you've done curette with your scoops, how do you improve it further? So it can be done with surgical technique by using high-speed burr, and that is the most important part which has led to decrease in the recurrence risk. Dr. Karunish was presenting the paper where he said the recurrence risk ranges between 10 to 65%. That was true traditionally, but nowadays the way we do it, we see the recurrence risk in extended curettage between 10 to 15%. In my personal case series, what I have around 100 cases, it is around 7.5. So it depends upon what grade of the tumor it is, Campanachi grade 1, 2, or 3. Other the chemical adjuvants are there. We will see. Do you prefer, sir, any chemical adjuvants?
So we do use hydrogen peroxide, but that was more empirical than based on any. It feels nice using it, and so it washes out everything.
Everything that is
we have not used phenol or liquid nitrogen, but I think earlier without the burr, I think they are used
liquid nitrogen
with the extended burr, with the high-speed burr. I'm not sure whether you really need to use that.
And for thermal, we have argon ring coagulation, or sometimes even with the cautery, they use that. Yes, sir.
I wanted a few just clarification for understanding it better.
Yes, sir.
Radiologist, sir, is the cortex broken?
So there is a focal breach.
So breach in the cortex. This is number one. How thick is the articular cartilage subarticular bone?
So I think it will be difficult to comment on just one film.
It's difficult to say, but it is reasonably thin.
Yes.
Now, if we take care of the subarticular bone and the brachiae, out of the whole thing, around 60% of it is in a precarious situation.
Yes.
How far we can go with the burr, not the extra lesional excision?
So there always has to be a balance between extended curettage, disease clearance versus your functional outcome. The other option would have been a resection, which is quite a morbid procedure. Considering this is a benign tumor, I would like to preserve my joint even with a reasonably little higher risk of local recurrence, but with the use of adjuvant, I am pretty sure that we'll have
one question to
Dr. The lesion, you say giant cell tumor extended into joint. So how can you prevent that?
So
joint has to go. For joint has to go, best way is excise the joint with the tumor and do acute docking, distract it, fuse the joint.
yes, sir, that was the treatment which used to be done. So I agree.
Cell is there.
So
sometime before they try to excise and put the joint.
So yes, sir.
Break in 5 to 10 years.
But
5 years.
So I come to that part.
Excise and fuse it. It will never come. It will give it solid nail for solid limb for life.
This case I had operated 4 years back. I'll just
Dr.
show some.
Vivek, can I have one question with Dr. John? So can we give injection denosumab before doing this procedure? Will it help or will have any role for that?
Okay, so denosumab is something which has obviously come up recently, and the role is still being defined. I think you would use it more for lesions which you cannot resect, bring it down to a size that you can resect, or in recurrence to bring things down before you do your definitive treatment. The problem with it is you have to keep giving. Okay, it's not that you give it once and it's over. Because when you stop it, then there's a chance of it coming back again.
Before such surgeries where it's
Not for something primary lesion like this, I would not use it, but
for this type of lesion, it would not help us much. It can, denosumab ossifies the mass, increase fibrosis, reduce neovascularization. So probably like for a lesion, large, huge lesion at proximal humerus where we do not have to meet or anything, I need to shrink it. When the margins are not clear, that would ossify it when I would have used. So coming to your point, you can see that the articular surface was preserved. Of course, the subchondral bone was very thin, and with the use of high-speed burn, considering keeping the balance, we were able to get good margins clearance. Considering docking and orthodosis, that is quite a morbid procedure. Of course, we counsel the patient for all the options, and depending upon what patient chooses. The risk of the other point, what you said that in another 5 to 6 years there is regeneration. That was a fact which was observed for long, and cement was considered the reason, the exothermic reaction which damages the articular surface. But over the time, it has also been proved that it also happens even if you use bone grafts, because ultimately what is more important is a good stability. Even if we use bone graft, it has to be well packed so that it does not cause secondary degeneration. You can also prevent exothermic degeneration by pouring cold saline while the cement is in the setting phase. So in this case, what we did was, this is something what you look with the after gross clearance, and okay, so it's not playing, only sound is the fine. So that was a video showing extended curettage with the high speed burn. Considering adjuvants, we have many adjuvants like John has said, using hydrogen peroxide. I also personally use hydrogen peroxide often, and but it is a personal preference. There are no level 1 studies that says that one condition which definitely proves that it reduces the recurrence risk. Bone cement is there, which has shown that it reduces the recurrence risk. So this is what it looks like, the cavity. You can see the difference. These are the septa, you can make it out. It's not that clear, but there are multiple septations which has to be burned out, and then we have to reconstruct the defect. So, John sir, what is your choice? Bone graft or bone cement?
So I think it depends on a few things: the size of the lesion, the availability of bone graft, whether you have access to allograft or not, because you can't always get enough autogenous graft.
Large cavities is difficult.
So for these huge lesions, especially for the older patients, we would use cement. But for the younger patient, we still try to use bone graft where possible, and we still use the sandwich technique, although now there's some
whenever it's like the articular surface is thinned out.
Yeah, when it's thinned out so much to prevent whatever exothermic reaction there is with the cement actually affecting the articular area. But now that, as you said, the evidence for that is not really very strong.
So any experience with using the bone graft substitutes we have? Like,
yeah, so we've combined bone graft with Chronos or calcium sulfate.
Yes, sir.
Yeah, so combine that with
both. Yes. But the cost is one important issue with those bone graft substitutes.
We don't have bone banks, so
yeah. So this is what sandwich technique is. If the articular surface is very thinned out, we can use morselize the autografts and then put it there and then pack it up the rest of the cavity with bone cement. So this was, so after that, in this case, we used bone cement, and there are different advantages and disadvantages of each, and I'm not going much into the detail. So this is what it looks like. Second, always, sometimes you have a dilemma, whether to use the plate or not, or we just pack it up with bone cement or bone graft. So I have to move to John sir only, sir. What is your?
It depends on your risk of fracture at the end of your curettage. And if you think there's a risk of it fracturing,
if it's a contained cavity, then probably we may just go away with
especially with cement, to some extent, you're less likely to have to use a plate. With bone graft, you may have to add a plate in some of them.
Yes, sir. Another in our series, yes, sir. Yes, sir. So I said it is, yes, sir. So yes, so the choice of reconstruction is a personal preference also, depending on how we are trained. In my training at Tata Memorial, we always used to have a bone cement, and how I have seen good results with it, so I go with it. But it is your convenience, the availability, the training that matters, and if you are comfortable with any one particular, you can go with that. Sir? Myself, so this is almost 4 years now, this case. Yes. Patient is all right. And like sir said, John said that when there is a contained cavity, we may you just put up a cement, but when it is a non-contained, the chances of cement also coming out is there. In my experience, what I feel that if your lesion is going quite higher towards the metaphyseal segment, then it's better to use the plate because then cement sometimes act like a stress riser and late chances of fracture are there. So I think time is up and I thank you all for your participation. Thank you all chairpersons and our panelists. Photographer, please, please. Yeah. President sir, Saraf sir, please, please. And thank you very much. Finally, we come to the end of our scientific program. It's all your effort. Bihar Orthopedic Association, in association with Global Orthopedic Forum. Thank you, everybody, all the delegates, all the pharmaceutical companies, all the respected faculties. We are honored that you together made it successful. A big round of applause for everybody, please. Thank you. We will meet soon in some other platform. Thank you.